and but still so just to brief, so here what these are the things I'm going to discuss within next half an hour. So yes, SARS-CoV-2, the virus causing this problem. As you all know, this is the virus that completely changed the world in 2020 and 21, but still its impact is still going on. So I'm not going to the details of the pathophysiology of this thing. Finally, what is actually happening is, as you know, when it's mainly infect the upper respiratory tract initially, and then it's involved the ACE type 2 receptors. As you know, its binding happen through the ACE type 2 receptor. It's gain entry into the body through this receptor. Then after that, what is happening? Yeah. So various pathways, especially involving the cytokine system. So what is called, as you already know or heard about the cytokine storm, involvement of the immune system that will lead into storm of production of cytokines, which lead to significant inflammatory response. With this inflammatory response is the one which lead into the significant tissue damage and finally deaths are reported in the patients with COVID-19, especially with pneumonia. And that lead into the development of ARDS, adult acute respiratory distress syndromes. Once they develop ARDS, so most of the time, especially in old age groups with and with patients with some other comorbidities, the prognosis were poor. Right. So these things now you know very well. When the COVID-19 virus gain into the body, gradually it's the viral genome, the number is increased. That means virus is replicating and leading to the infection. When the viral load is going up, alongside the inflammatory response appear. With that, the symptoms appear, and then usually the mild disease resolves within first week of infection. By 10 days, usually the symptoms settles and patient become normal. But sometimes, some proportion, they develop the severe illness, or further disease might further progress, especially leading to this critical illness, leading to shock, severe respiratory failure, ARDS, and sometimes, as you know, children develop MIS-C, the especially mysterious syndrome, multisystem inflammatory syndrome in children. So those are the pathophysiological process that lead into final problems in these kids with COVID. And so this is the problem with the virus. Initially, the virus causing the symptoms, early phase of this viral replications, but later is the host inflammatory response. That was the main reasons to develop significant morbidity, especially cytokine storm associated inflammatory reaction, which led to the significant tissue damage and death in these patients with COVID-19. Right. Okay. We're going to this. Right. So, what is happening in COVID-19 with this pathophysiological process? The disease we can categorize it to mild disease, moderate disease, and severe disease. With mild disease, obviously, the only few symptoms are there, especially upper respiratory symptoms. But the most important thing is patient can manage saturation. At moderate disease, there is some hypoxia in room air and severe disease. So hypoxia is one of the important factor, one of the important determinant of the prognosis, so the outcome of these patients who develop COVID-19, especially moderate to severe disease, or when they develop this significant inflammatory reaction. So the main cause of death initially was the hypoxia and lung damage, and various secondary causes were there. But the COVID-19 means it's respiratory issue and the hypoxia. So before going into that, the mechanisms of hypoxia and hypoxemia, we have to differentiate what is hypoxia and hypoxemia. Two different terms, two different meanings, but sometimes we are using this interchangeable, but obviously two different. Can anyone give the difference between? I don't think this is just a lecture series. This is some discussion. What's the difference between hypoxia and hypoxemia? Can someone turn on your microphone and
So
give the
I
answer?
think hypoxia is
Yes.
when there is less oxygen in the tissue level, and
Oh,
hypoxemia is about the blood.
a few names. K.D. Senuri.
I'm Arachi, Madhu Maharaj.
What's the difference? Hypoxia, less oxygen
Hypoxia
to the
is at
tissues. Okay,
tissue
great,
level, and
right?
hypoxemia is about
Hypoxemia,
the blood.
yeah. So the hypoxemia, yes. So the reduction, simply reduce oxygen supply or the oxygen contained in the blood. Hypoxia is yes, the lack of oxygen at the tissue level to meet the metabolic demand. Yes, so that's the difference. So hypoxemia decreases the partial pressure of oxygen in the blood, and usually we consider as the 60 millimeter mercury as the cutoff. And hypoxia is the reduced level of tissue oxygenation, especially because of this, the cells lacking sufficient number of oxygen molecules to complete the metabolic function. So to meet the metabolic demand, the number of available oxygen molecules are reduced. That is hypoxia. Is that the tissue level? Yes. Hypoxemia leading cause of hypoxia. When the blood oxygen level is reduced, obviously the tissue oxygen level is reduced. But that is not happen always, or vice versa, also not happen always. Sometimes hypoxemia would be there, but without hypoxia, the blood oxygen level would be low, but still the patient can manage the metabolic demand, can manage with the available tissue oxygen. That is without hypoxia. Any example? Hypoxemia without hypoxia? Yes. Hmm? Yes, yes. Any example? Yeah, patients with congenital cyanotic heart diseases, cyanotic heart disease. The cyanosis means the oxygen level in the blood is very, very low. That's why they develop the cyanosis. But they don't develop hypoxia. That means various mechanisms are there. The hemoglobin level will be increased, and there are some changes in the 2,3 DPG levels. Various mechanisms are there. So finally, the tissue can use the available oxygen, whatever the available oxygen level, although the blood oxygen level is less. So that means there's no tissue hypoxia. Some children with because of these compensatory mechanisms, right? Other thing is sometimes hypoxia can develop without hypoxemia. The blood oxygen level is pretty much well, but still the tissue level, oxygen level will be low. The classic example is cyanide poison. Sometimes even with some localized causes leading to impaired perfusion, maybe some local issues or circulation issues. Local circulatory issues can lead into reduced tissue perfusion and hypoxia, but the blood oxygen level is normal. So that is the difference between these two terms. Okay, so what are the causes, main mechanism of hypoxemia? Why the blood oxygen content can reduce? Right? Obviously, there are 5 mechanisms. I'm not going to the details. Just to recap your memory, or what you have learned during your physiology. Yeah, obviously, when the low inspired oxygen level is low, especially like practically high altitude like conditions, obviously the amount of oxygen which we can get into the body is less. So obviously the blood oxygen level will be reduced. This is very important, especially when you are going high altitude. That's why we have to carry a oxygen tank. And then the mechanism, the hypoventilation, the ventilator mechanism is impaired. It may be related to respiratory system or outside the respiratory system. For example, CNS problem or CNS, especially sometimes maybe drug induced hypoventilation, reduced ventilation causing obviously pump failure and hypoventilations leading to hypoxemia. And diffusion, obviously the oxygen in the alveolar space gradually diffuse with a simple diffusion in the blood. If there's a problem with this alveolar capillary membrane, there are some thickening, various problems will be there, then lead into the reduction in the blood oxygen level. So that is hypoxemia. And sometimes right to left shunts, right side blood or deoxygenated blood directly shunting into the left side, leading to shunts. This shunt may be within the lung, or outside the lung, like congenital cyanotic heart diseases. And the ventilation perfusion mismatch, this is a little complex form, but this is usually the commonest form of hypoxemia in patients, especially due to some conditions, pneumonia or respiratory diseases causing ventilation perfusion mismatch. The ventilation perfusion should be ideally 1:1. The ratio should be 1:1 to get all the oxygen or the available oxygen into the blood circulation, into the capillaries. Sometimes the ventilation would be cut off, then the circulation is there. So the ventilation perfusion is 0, the ratio is 0. This is obviously not suitable. Sometimes the ventilation is normal, there might not be, the alveoli might not be localized due to some perfusion issues. The perfusion would be 0. Then the VQ, the ratio would be infinity, but the ideal way is it should be equal 1. The VQ ratio it should be equal. So when there's a mismatch, they can develop hypoxemia like this. So example here, this alveoli, because of this obstruction, it's become 50. The available oxygen for the gas exchange, the normal alveoli, usually the alveolar partial pressure of oxygen is 100, but here because of this obstruction, it become 50. And so here the 100 will come diffuse into the oxygen with a simple diffusion. Here it become 50. So finally there would be get some equilibrium diluted, and this is the final FPO2. This is the reason to develop this hypoxemia in patients with ventilation perfusion mismatch. And if you give oxygen, we can increase the oxygen alveolar oxygen content. Because of that, we can increase the arterial oxygen as well. So the hypoxemia due to ventilation perfusion mismatch can be easily corrected by supplemental oxygen therapy. So that is one of the important principles. That's why we are giving oxygen to increase the alveolar oxygen, and then unless there's a diffusion problem, it's diffused into the capillary system, and finally the blood or the arterial oxygen level will be increased. But problem is, if there's shunt, obviously, even though we give oxygen, it cannot increase the oxygen level. Right. The other thing is, I'm not going to details about this AA gradient, alveolar arterial gradient. So the alveolar oxygen level, usually it's around 100, and the arterial, because of the simple diffusions, it's also should be 100, but there are some physiological shunts, as you know, Thebesian veins and like that. So because of that's become 95, but up to 10 would be allowed. So because of that, the usual AA gradient, the alveolar and arterial oxygen gradient, the difference between the alveolar oxygen and the arterial oxygen would be usually 5, but up to 10 we can accept, up to 10 difference. If that is more than 10, that means there is a significant alveolar arterial gradient. So why it is important? If we identify child with hypoxemia, and we have to get this alveolar arterial gradient through blood gas, and then the gradient is normal. If there is normal, then it's very simply due to hypoventilation. The gradient is increased, VQ mismatch, diffusion, and shunt. And if we give oxygen, only the hypoventilation, VQ mismatch, and diffusion will be responded, but shunt obviously does not respond. So just remind this is important. This chart, then you can work it out while you are working in pediatric ward, especially if a child is having hypoxemia, and if you want to identify what is the possible cause of this hypoxemia, you can start oxygen and see the response. And if there's a shunt, obviously the response to oxygen is poor. Whatever the things we give, the number of hemoglobin is low, and we cannot increase the amount of oxygen, and it's mixed. And only thing is we can increase the dissolved amount of oxygen, very, very minimum amount. Right. So how they develop COVID-19 in patients hypoxia? So as I discussed, there are 5 methods of hypoxemia in COVID-19. So, okay, so obviously the atmospheric pressure won't be a problem in a practical clinical scenario. So we have to get alveolar arterial gradient. If the gradient is normal, hypoventilation. And if the gradient is widened, VQ mismatch, diffusion limited, and shunt. Okay, so those are this is actually a very important summary slides. Especially this is important for your even you are doing postgraduate examinations, but at least as a house officers or when you are doing working with children, this is important, right? Okay, shunt, obviously there's no response to oxygen, right? So in COVID-19 patients, so ventilation perfusion abnormalities can happen, right to shunt happen, diffusions, many things can happen. Pathophysiology is a complex phenomena. Sometimes they have diffuse lung diseases, right? Sometimes they have atypical features. So significant vascular disease, that's the main problem, as you all know. The COVID-19, the problem is microthrombi formation. So there's a significant problem in these vasculature. So this microthrombi causes free distribution of the normal flow of blood within the lung, and that increase VQ mismatch, ventilation perfusion mismatch is increased. So that's an important thing. In addition that they can develop intrapulmonary shunts within the lungs, they can develop shunts. So because of that, the oxygenation would be impaired because it's going directly to the from the right side directly go to the left side without oxygenating. So those are the important things, and obviously auto-regulation is limited. So all these things lead into the significant ventilation pre-position mismatch and hypoxemia in children with COVID-19. So other thing is this changes in vascular permeability increase the content potential fluids for accumulation. So that's the other thing. So as you may heard, like in dengue fever, this is also not that much but small vascular permeability increases. That's also leading to the fluid accumulation. Right. So other thing is this hypercoagulability. This is one of the important things we are discussing, especially children with the patients with COVID-19. So hypercoagulability leading to thrombi formation, and that also can lead to significant complications. We want identify whether this patient is having hypercoagulability. So you can do this investigation, D-dimer, fibrinogen like things. Okay. And the problem is, why do they develop these things? Because of this SARS-CoV-2, the viral induced epithelial damage. So this is the summary of what is happening really. So this is the the normal epithelial cells, and with damaged endothelial cells, some of these surface antigen get exposed, and that lead into the activation of this the epithelium of the vessels, and that lead into the microthrombi formations. This is some sort of a DIC, localized. I don't have to usually the diffuse thing that much of the severe initially. That's why the D dimer level is increased. Okay. And then when the COVID is going on in peak days, some literature have identified different types of alveoli, type A alveoli, type B alveoli, and I'm not going to the details of these alveoli. These are little theory. So the thing is, this is the problem. Yeah, so this is the problem. So this is a normal alveolus with the associated the capillary. You can see nicely the single membrane. The basement membranes are touch each other. It's effectively allowing the filtering. But sometimes with this problem, with this involvement of the macrophages, sometimes with microthrombi formations, this process will impair. So in the fluid, exudative fluid is can accumulate within the lumen of the alveoli. In addition, sometimes can induce some inflammatory pathways, as well as these cells can directly damage and increase the vascular permeability. So here the lungs also can damage. All these things finally lead into the hypoxia or hypoxemia most of the time. Right. So this is the problem. This is oxygen level, PaO2, the onset of the disease. And when they start to develop this intravascular thrombi, gradually, their clinical scenario, the clinical condition get. So you can see this is oxygen therapy. Can ventilation required in this stage? Sometimes. So this is the critical stage. They require oxygen supply, ICU care, supportive care, but sometimes even with those things, might not be able to recover these patients. That's the main problem in SARS-CoV-2 or the COVID-19. And this is a practical example, true example of this. But however, this is an adult patient, initial CT actually. Then there's some changes developing. This is called ground glass appearance, and then resolves spontaneously. So this is the usual natural history in patients with a lung involvement. Initially, lungs are perfectly normal, then they develop some changes within the lungs, and then it become worse, and then gradually recover. So this day, by day 15, it's almost recovered now. Okay, so other important concept. This is not only related to the COVID-19, but during this COVID-19 pandemic, the silent or happy hypoxemia, the term came into the discussion. So this is here, pronounced arterial hypoxemia without proportional signs of respiratory distress. So as you know, when there's a hypoxia, the patients develop breathing difficulties, and they feel that because there are a lot of mechanisms are going, especially the reflexes are there in the chemoreceptors, but still here this function is impaired. So because of that, even the child is significantly hypoxic, child doesn't show significant evidence of breathing difficulty or the use of accessory muscles. So then sometimes the percentage would be low. Unfortunately, in large also we got one child finally died. So because of this later presentation, it's silent hypoxia. Although this child was severely hypoxic, child didn't develop significant respiratory distress. So that is why it's called silent or happy hypoxemia. Right. So yeah. So it is important. Subtle changes in the breathing pattern may serve as early warning signs of implementing hypoxic respiratory failure in COVID-19. That's the problem. Sometimes they might show some evidence, but still the patient might ignore or might not identify if it is the case. So those are COVID-19 positive cases, especially. They might not be able to completely catch these patients. And then the late presentation, if the presentation is late, the problem is unnecessary deaths. So even LRH has happened, silent hypoxia. So then how to identify this? Obviously, the COVID-19 during this pandemic, lot of popularity gained by this small gadget, the finger pulse oximetry. So that's the best way of assessing the hypoxemia. Sometimes with the symptoms only in this situation might not be able to attend. Okay, so there is another important concept as we're discussing this hypoxia and hypoxemia. How do we assess the blood oxygen level? So obviously we are assessing the blood oxygen level through this, or maybe we have the larger monitors with the pulse oximeter. The pulse oximeter, what's the principle? So this is the oxygen dissociation curve. I'm sure you know this. This is the bow-shaped oxygen dissociation curve. And according to this curve, you can see the saturation is 90%. So this y-axis is saturation, x-axis is the oxygen partial pressure, oxygen tension. When the saturation becomes 90%, the partial pressure of oxygen in the blood is 60, right? If it is become 80%, right? So because of the shape, it become 40. So 90 become say 75, right? 90 becomes 75. Here, saturation, that means just 15 drop in saturation, but leading to significant over 20 drop in the school performances. So that especially these patients oxygen level, right? So with that, they can develop various other types of disease problems, including if it is a chronic problem, school problems and other things. But in acute situation, so that is the important thing. That's why we are using this saturation probe as a surrogate marker of blood oxygen levels. How do we check the blood oxygen level? With the pulse oximeter, sorry, the blood gas, but we cannot do blood gas repeatedly. So because of that, we are using this pulse oximeter as a surrogate marker of blood oxygen level. Okay, right. So this is the principle of we are using this pulse oximeter. The pulse oximeter, as you all know, is red in color. The light in the pulse oximeter is red. I'm sure you haven't seen green color or blue color pulse oximeters because it gives red color and the infrared, two wavelengths, 660 and 960, two wavelengths, red color and the infrared color. So this red color, the deoxygenated blood absorbs red color, oxygenated blood, oxygenated hemoglobin or the deoxygenated hemoglobin absorb the red color, and oxygenated hemoglobin absorb the infrared wave. So two waves forms, and then this detector detect how much it has absorbed or the saturation. Then we can get the relative proportions of this. If the absorption is more, that means the if the red color absorption is more, that means deoxygenated hemoglobin absorption is more deoxygenated hemoglobin. If the absorption of infrared the wave is more, that means more oxygenated hemoglobin is there. And with that, the machine make the calculation, right, like that, low absorptions with high absorption, and make some calculations, and finally you can get the pulse oximeter reading. Okay, at the same time the machine can assess the or the detect the heart rate as well. So to get the pulse oximeter reading, it needs a pulsatile waveform. So that's why the arterial form is important, not the venous blood. It's the arterial blood saturation is detected through the pulse oximeter. Right. So this is I'm going to the details of this thing. Okay. So other important thing is why hypoxia is important. Why hypoxemia is important? Because there's a vicious cycle: infection and hypoxia and its related inflammations. When there is infection, especially respiratory system involvement, leading to significant hypoxia or hypoxemia, and then when the especially hypoxia, the tissue hypoxia happen, that leading to the increased inflammation. So then this will act as a cycle. So when there's a hypoxemia, some tissue inflammation, further tissue hypoxia, that further leading to the hypoxia, it can continue as a vicious cycle. So we have to break this cycle. How do we break this cycle? How do we prevent hypoxia? Hypoxemia, we have to give oxygen. So severity of hypoxemia is an independent association with the hospital mortality. Okay, so it's an independent determinant of mortality in patients with COVID-19, not only COVID-19, any disease conditions, and can be important predictor that the patient is at risk of requiring admissions to the ICU. And the correct recognition of hypoxemia has such impact on a prognosis, and timely treatment is very, very important. So how do we manage patients with COVID-19? I'm not going to details, just principles. One of the important thing is to closely monitor these patients. Monitoring is important. So deteriorations, we have to identify them early. And signs of hyperventilation, oxygen saturation is important, as we discussed the principles of pulse oximeter. So sometimes invasive measurements might be required. And the most important thing is use oxygen appropriately. So appropriately use oxygen. That is other important thing, especially when you are dealing with children. Unnecessary oxygen use. One thing is oxygen wastage. Obviously, oxygen is a drug, and it seems to be the mostly misused drug is oxygen in our part of the world, right? Oxygen is a drug. That means there should be clear indication. There should be clear prescription, the dose, the liter per minute, and the duration of treatment, and how to wean. All these things are important. So oxygen is a drug. Don't just increase the oxygen level, or don't just turn the regulator knob without getting all these things appropriately. So it's important to give oxygen as well as to give oxygen appropriately. So while giving this oxygen, you can see the COVID-19 infection, viral replication happen, pulmonary infiltrates, and so all these things can lead into the cytokine release, and cytokine release is a positive feedback loop, finally leading to significant tissue damage. If we give oxygen, then and there we can reduce this inflammatory response, because oxygen supplementations will reduce this cytokine release and improve the outcome of these patients. So other thing, I think this was initially discussed in the early part of this COVID-19, the prone positioning, one of the main method adopted, especially if a patient is hypoxic. The prone positioning, you can see the supine position and the prone position. The advantage in a patient in a supine position, the weight of the heart is also the lung. But when the patient is in a supine position, prone position, the adequate space is there to lung to expand. Though there is no weight of the heart, the lungs should not have to bear the weight of the heart. Supine position, that is the case. But here, yes, other thing is this, the compressive effect of the abdominal organs also reduce. And so other important thing is just all expansion. So in the supine position, rather than supine position, the prone position, the lung expansion is also increased. So because of that, this was adopted mainly during this COVID-19. Any time, any patient, if there's a hypoxia, you can improve the oxygenation or improve the hypoxemia by keeping the patient in prone position unless it is contraindicated due to some other reasons. Okay, so in summary, hypoxia is one of the major factors which lead to morbidity and mortality in COVID-19. So different pathophysiological processes in addition to usual ARDS. Microthrombi formation is one of the important pathophysiological process. Other important thing, we should not miss this hypoxia, silent hypoxia. Early identification is the key in the management, successful management, because actually we have scientifically analyzed the causes of death in children due to COVID-19. So we have identified one of the main reasons for this death with COVID-19 was late presentation, late diagnosis and late presentations, keeping in local hospitals without proper treatment, right? And then, so there is the early identification and early diagnosis is the key, and appropriate use of oxygen and respiratory support is the mainstay of management, because still for COVID-19, we don't have a proper drug or other treatment modality. Thank you. Do you have any question?
So today we are going to this morning we are going to good morning. Sorry for that. This morning we are going to discuss about high flow nasal oxygen therapy. So in this lecture, you will understand what is a high flow nasal cannula system and also how it works. Then the indications and contraindications of high flow nasal cannula therapy, and how to select cannulas and flow rates in patients, and what to monitor, when to escalate during high flow nasal oxygen therapy. So these are the objectives. So this is a high flow humidified high flow nasal oxygen therapy system applied to a patient that you can see. So this system can provide flow rates from 2 liters per minute to 60 liters per minute. So what are the features of a high flow nasal oxygen system? So there are mainly 3 features. It is an open delivery system. It provides optimal humidity at optimal temperatures. And also it provides gases at high velocity. So this is a cartoon of a high flow nasal oxygen system. As you can see, there is a water reservoir which is pumping water to the humidifier. Here there is heat generation, and within the humidification chamber there is development of water vapor. And connected to this humidification chamber is the oxygen source. By manipulating this, we can increase your oxygen flow rates. So this oxygen rich gas will mix with the humidified with the water vapor, and then it's taken into the patient end via this circuit. And to prevent the water vapor being condensed at the patient end, the circuit is heated. You take the look at the nasal cannulas and the tubing, you can see this, that there is a wire running through this and it's heated. So this is the simplified version of a high flow nasal oxygen system. So I said that it is an open delivery system. What I meant to say is that when you apply the nasal cannulas to the nares of a patient, it should occlude only 50% of the nasal diameter. So there should be room around this nasal cannula for gas to flow in and out. So that is why it's called an open delivery system. And I mentioned that it provides optimal humidity at optimal temperature. So why do we need humidification? Because usually medical gases, they are dry gases. They don't contain oxygen, humidification. So if you give dry gases to our respiratory passage, it will dry up our secretions. The mucus secretions will be dried, and the natural mucociliary clearance mechanism will be disrupted. So whenever you provide humidified gas, this will prevent drying up of the water vapor, will prevent drying up of the mucus layer, and that will allow this cilia to beat in the natural beat frequency, and this will facilitate the excretion of mucus through the respiratory passage. So that is why you need humidification. And gas is delivered at a high flow velocity. This velocity can be from 2 liters to 60 liters per minute. So now let's go to the history of the evolution of high flow nasal oxygen therapy. So this system was derived from the experience of a patient who had bronchospasms with pulmonary edema. She was rushed to the hospital by her husband driving at a speed of 130 kilometers per hour. And she held her head out of the shutter. That created some easing breathing. And this experience was divulged once she was recovered. And that led to the development of research and ultimately the high flow nasal oxygen therapy. So they found out that at a speed of 130 kilometers per hour, it created a pressure of 8 centimeters water at the level of the nares. So what is the importance of this positive pressure in the airway? So then people have done research measuring the pharyngeal pressure, as you can see in the y-axis, against the gas flow, liters per kg per minute. So as you can see, when you are increasing your pharyngeal pressures, when we are increasing your gas flow rates, liters per kg per minute, from 0.5 to 1 liter per kg, 1.5 to your pharyngeal pressures also rise. But now this doesn't continue as a straight line. So people have studied pharyngeal pressure of high flow nasal cannula in premature infants. and they had measured the end expiratory pressure in water centimeters at the level of the pharynx against the flow rate. As you can see, at a flow rate of 2 liters per kg per minute, lot of patients scatter around this area. As you go increasing the pressure, minimum amount of patients are there. So at rates between this 2 to 3 liters per kg per minute, you create a pharyngeal pressure of around 4 to 5 centimeters water. Right? So this was the basis for this development of flow rate. So based on these studies, they have come to a conclusion that we should prescribe a gas flow rate of 2 liters per kg per minute to get this optimal pharyngeal pressure. So that is how it has been derived. So when you put patients on high flow nasal oxygen therapy, you have to write the prescription. So the flow rate should be 2 liters per kg per minute. 2 liters per kg per minute. Right? So in this cartoon also you can see the airway pressure against time. So during an unsupported breath, during inspiration, the airway pressure becomes negative, and in expiration it becomes positive. When you support it by your breath by high flow nasal oxygen therapy, as you can see, the inspiratory part, which was negative when you are unsupported, has been converted to a positive airway pressure. Whereas the positive part of the expiratory phase, which was positive, almost positive, the airway pressure, the amount of positiveness has been increased. So this is what happens when you apply high flow nasal therapy. You create a positive airway pressure in the pharynx during inspiration as well as in expiration. So what's the physiology behind this? So this is the physiology of reduction of work of breathing. So when you apply high flow nasal oxygen therapy, you can see that the patient's work of breathing, it declines markedly. So this is what happens. So this is the pharyngeal pressure in water centimeters during inspiration and expiration. Inspiration is negative, expiration is positive. This part is in an unsupported normal breathing patient. Here, in a supported breath with high flow nasal oxygen therapy, you can see that the pharyngeal pressure has become entirely positive even in inspiration. Then also they have measured the esophageal pressure, PES is esophageal pressure, and that during inspiration and expiration. So this swing, this part is the inspiration and this part is the expiration. So this, you can see when you apply high flow nasal oxygen therapy, the degree of swing is reduced. Without support, you need to create a negative pressure of minus 40 centimeters water. Whereas with high flow nasal oxygen therapy, it's somewhere around 10, minus 10. So the degree of negativity in the esophageal pressure has been reduced. In the sense, now this negative pressure is created by use of the diaphragm and accessory muscles. No? So then when you apply the high flow nasal oxygen therapy, you can see that the degree of use of the diaphragm and accessory muscles has been reduced. So they measured the time duration to which this negative pressure has been applied, TR, inspiratory time. Right? And they created a product. The pressure times the pressure into the time. This pressure is applied. And this is called the pressure time product, which is equivalent to the area that has been colored. So without support, you can see the pressure time product is this area. With support, the pressure time product has reduced to this much. So this is equivalent to the reduction of work of breathing. So this is done by applying a positive pressure at the level of it works, reduces the work of breathing. So gas dynamics during high flow nasal oxygen therapy. Now I said it's an open system, and this is required for the proper functioning of the high flow nasal oxygen system. So when you apply the nasal cannula, gas flows through your nares and to the upper airway, right? And part of this gas at the level of the pharynx will come to your mouth and is dissipated outside. So whatever the gas that has been expired, now gas, when we exhale, this gas comes and accumulate here. No, this is your dead space. So when it combines with this the gas that has a high velocity, it drags this expired gas outside. That's how it clears your carbon dioxide. So the open system and the gas dynamics. So spontaneous expiration will fill your dead space with carbon dioxide rich gas. And when you apply the high flow nasal oxygen therapy, high velocity gas is will wash out your dead space rich in carbon dioxide. And also it will help to drag out this gas that is rich in carbon dioxide accumulating at the level of the pharynx, further reducing your carbon dioxide. And with the next inspiration now, instead of carbon dioxide rich gas that you should occupy the dead space, now there is oxygen rich gas that is going to be inspired. So by that it increases your fraction of inspired oxygen. So what are the impacts of high flow nasal oxygen therapy? So it conditions gas flow to be delivered at high flow rates. So it decreases the work of breathing due to nasopharyngeal resistance by providing a positive pressure. It flushes the anatomical dead space, as I have explained previously. So it provides lower levels of airway pressure and reduces the work of breathing and gas and the temperature that is needed for gas conditioning. Thereby it reduces your energy expenditure. It improves your mucociliary function by good humidification. So because it reduces your work of breathing and washes out of your carbon dioxide and improves oxygenation, the need for mechanical ventilation has been drastically reduced by the use of this machine. Because of that, it has reduced the exposure to sedatives and analgesics that are used in mechanical ventilation. These are the impacts of high flow nasal oxygen therapy. Now let's look at the indications. So it can be applied to any respiratory condition, starting from bronchiolitis, pneumonia, asthma, then heart failure with pulmonary edema, also for post-extubation care, post-cardiac surgery, and even during intubation and extubation, right? So during intubation, you can apply the high flow nasal oxygen for pre-oxygenation, right? It will wash out and you can keep this high flow nasal oxygen therapy while you are intubating, because you are using the nasal nares only, right? You are not going to occlude your oral passage, right? So contraindications. So obviously your nasal passage should be intact for the mechanisms to work. So in coronal atresia, you cannot use this. In cases where you're under the effects of toxins or various ingested material, if your GCS has dropped so that you cannot maintain your airway protective reflexes, then you cannot use this high flow nasal oxygen therapy. So what are the airway protective reflexes? The cough reflex, gag reflex, and the swallowing reflex. So these should be intact for the use of a high flow nasal system. Life-threatening hypoxemia and respiratory failure or hypercapnia is not a time to use high-flow nasal oxygen therapy, the patient needs intubation and mechanical ventilation. Then trauma to the basal skull or the involved area where you are applying the nasal cannula. Pulmonary aortic syndromes is said to be a contraindication and foreign body aspiration. But I think in the near future, you might see that they will remove these pulmonary aortic syndromes because it has been safely used in pulmonary aortic syndromes. Even in ICU, we use it. So for now, just remember that pulmonary aortic syndrome is a contraindication, but in future, I'm sure it will be removed. Then what should be prescribed when you put a patient on high flow nasal system? FiO2, flow rate, temperature, and the mode, whether it's a pediatric or adult mode. So the FiO2 will depend on your disease conditions. There are some diseases which require high FiO2, and in some disease conditions, they are giving high FiO2 will be detrimental. So depends on that, we have to decide that. Flow rates, of course, always 2 liters per kg per minute. Temperature, the normal temperature 37 degrees Celsius, and the mode pediatric or adult. Then we should select the cannula size. So as you can see, cannulas vary from extra small, small, medium, large to extra large sizes. And the size is going to be determined by the nasal diameter. As you can see here, you should not completely occlude your nares. You should only 50% occlude the nares. So, so you have to keep look at the nasal diameter and then select the size of the nasal prong that is needed, right? At the same time, you should calculate the flow rate of the patient. So 2 liters per kg. If the patient is 5 kilos, then you should provide 10 liters per minute. And that cannula that you selected should be able to provide this flow rate. Right? So you can see the flow rates from 0.5 to 8 liters per minute, 0.5 liters per minute, 9 liters per minute, 0.5 to 10 liters per minute, 0.5 to 23 liters per minute, and 0.5 to 25 liters per minute. So these are the pediatric ones, right? After 25 liters per minute is the pediatric flow. Right? Then after that, we have to use the adult rate. So first calculate the flow rates in 2 liters per kg per minute. Then also look at the nasal diameter and select a prong that can provide the flow rate plus that will occlude only 50% of the nasal diameter. That's how you select it. So once you put a patient on high flow, then you have to observe this patient, start monitoring the vitals, which are the respiratory rate, heart rate, work of the temperature, oxygen saturation, FiO2 requirement, and the work of breathing. These should be monitored. So these are some findings of research that people have done. What they found is that by 10 minutes, the heart rate will reduce. By 5 to 15 minutes, there will be reduction in respiratory rate. By 15 minutes, there will be improvement in oxygenation. By 10 to 30 minutes, the work of breathing will be less. And thoracoabdominal asynchrony will be reduced by 30 minutes. Now, these are research findings. Don't go to memorize this. This is not just for your information. Okay. All right. So once you have put a patient on high flow, then you have to monitor the vitals, as I mentioned previously. And if the patient is improving, you can continue. If the patient is not improving or worsening, then you have to escalate therapy. So when should you consider escalation? When the patient is not stabilizing after 2 to 4 hours. Worsening respiratory distress. In the blood gas, if you have done one just before starting the high flow, and at 4 hours, if there is persistent hypoxemia despite high gas flow, if the oxygen requirement is increasing above 60%, you can think of escalation. So if the patient is rapidly deteriorating, you should do an urgent chest X-ray and also think of pneumothorax and examine and see whether there is pneumothorax and attend accordingly. So this is what happens to respiratory rate versus time. So this patient, you can see, they have started high flow nasal therapy here, right, on 2 patients. Both had high respiratory rates to begin with. This patient with time has not that responded, isn't it? And this patient has shown a drastic reduction in the respiratory rate. So always look at this pattern of the graph. So that will give you an idea to whether to escalate or not. Now this patient needs escalation here. Here, this patient is responding to high flow nasal oxygen therapy. Right. Heart rate versus time. You can see 2 patients having a tachycardia, started on high flow nasal therapy at this point. 1 patient, the heart rate has nicely come down. It's coming down. And in the other patient, the tachycardia is still persistent. So this patient is not responding, whereas this patient is responding, given that his oxygen requirement is reducing, work of breathing is less. Your heart rate can come down sometimes in conditions, in terminal conditions. So don't go only by the heart rate, right? Right. Okay. So if the patient is improving, you can continue high flow nasal oxygen therapy and treat the underlying disease and give adequate time for your underlying disease to settle. So once the patient's underlying disease has settled, then you can start weaning off the high flow nasal cannula system. So how do we wean? We start by weaning the fraction of inspired oxygen, or the FiO2. We slowly come down looking at the saturation. So once you have weaned off the fraction of inspired oxygen to 30%, then you can directly remove the nasal cannulas. So remember, we don't wean off the flow of the system. We just come off the nasal cannulas once the FiO2 is at 0.3% or at 0.3 or 30%. Nursing care during high flow. So you have to check the nasal prong position early at a minimum to ensure that a leak is present. Otherwise, the system doesn't work. And also, you can see in patients with bronchiolitis that they have a lot of secretions, and this can obstruct your nasal prongs as well as the nasal, the space between the cannula and the nares. And this creates increased work of breathing. And sometimes patients are transferred to the ICU because their breathing pattern is not good. So the simple thing to do before that is to check the nares, see whether there are secretions, see whether the nasal prongs are obstructed, suck out the nares, suck out the prongs if they are obstructed, and put it back to the patient, and you will see that there is a drastic reduction of the abnormal breathing pattern. So these are commonly occurring error, right? Preventable thing. And also this, if your prongs are too tightly fitted or not properly positioned, it can cause pressure areas on the nose, nares. So, and this should be looked out as well. So perform nasal hygiene to prevent crusting of secretions and perform effective nasopharyngeal suctioning. And remember that all children who are on high flow nasal cannula system should have a nasogastric tube in situ, because some of this gas can be swallowed and it will cause gastric distension, and that will further hinder your diaphragmatic movements. So to prevent this, you have to put a nasogastric tube and monitor the saturation and rotate the saturation probe attachment. So can I feed on high flow nasal oxygen therapy? Yes, you can, once your acute condition has settled and the patient has stabilized. You can start nasogastric feeding initially, and if the patient is tolerating that and the acute scenario is improving, underlying disease is improving, then you can slowly increase your nasogastric tube feeding, and later on even you can give the suck. But this should be done under close observation. So during the acute situation, because you cannot feed, then of course you have to use intravenous fluids. Can I nebulize on high flow nasal oxygen therapy? Yes, you can. It's a very effective mode of nebulization, but you should have the appropriate equipment for nebulization. So this is the nebulization chamber, that's a special chamber, and this is the chamber where you put your nebulization solutions, and this is the power source. So this is the nebulization chamber. That should be attached to the humidification unit. Yeah, this is the device for nebulization. You put your nebulization liquids into this, and this is the power source, and this part is attached to the humidification chamber. So as you can see, this is a different humidification chamber, and this is the normal humidification chamber. This should be specifically ordered for the unit. This is the power device and for the nebulization. Right, with COVID-19, people did research on aerosol generation and found out that when you put patients on high flow nasal oxygen therapy without a mask, it creates a lot of aerosols because it's an open system, right? And you are washing out your dead space here. And that's a risk. You can see that this is the amount of aerosols coming out of the patient. But this could be prevented by applying a simple facial mask. So what they use is just a simple face mask applied over the nose and the mouth with the high flow nasal cannula system, and it's safe to use. So take home messages are high flow therapy is now dominating the treatment of acute respiratory distress. So is illness severity. It can be mode of rescue. Right? Standard oxygen therapy failing, you go for high flow nasal oxygen therapy. And you safely come, recover, put on nasal prongs, and you are off. For those who are not settling only, you can try CPAP, BiPAP, mechanical ventilation. Then you can come down, de-escalate to BiPAP, CPAP, and on high flow. So it's a mode of de-escalation as well. It's a mode of escalation as well as de-escalation, and it's dominating the field, reducing the mechanical ventilation now. And also remember, in patients with infectious diseases like COVID-19, influenza, you can use the high flow safely, but only thing you have to use a simple face mask, cover the nose and the mouth. This will prevent large amount of aerosols dispersing in the unit. Okay, that comes to the end of the lecture. Thank you very much for listening.
Now tea break 10 minutes. Please come 9:35.
Okay.
Go with me.
Next lecture is by Dr. Sandhya Doluvira, consultant pediatrician at Casa Street Hospital for Women, the topic of vascular access in children. So, over to you, madam.
Hello. Hari ma pata ganna. Hari. Okay, thanks. Hello, good morning.
Good morning, madam. Can hear?
Can you see the slides?
Yes, madam, can see.
Right, okay. So good morning to everyone. I'm Dr. Sandhya Doluvira, a pediatrician attached to the neonatal unit at Casa Street Hospital. So the topic now is about the vascular access in children. So even though the topic sounds very simple, it is an important topic, I would say, because as you know, almost all the patients admitted to the hospital need some kind of a vascular access. And in children, it is often challenging for obvious reasons. So they are not as cooperative as the adult, and their veins are small, and also you have to perform it in front of the stressed parents, right? So it's important you to master the art of it and develop the hands-on skills. So what are the indications for the vascular access? You have to give IV fluids to correct dehydration or to maintain the hydration, especially for those who are unable to tolerate sufficient volumes orally. And then it's needed to administer drugs or medication, and also transfuse blood or blood products, and also to draw blood for investigations. There are certain important principles that you have to follow when obtaining vascular access. For example, it has to be done under strict aseptic conditions. Safety is very important, both for the patient as well as for the performer. And also throughout the procedure, both parties have to be comfortable. With regards to the asepsis, the 5 steps of hand washing is very important. Make sure you remove all the germs from the hidden areas in the hands, which is marked in red in this picture. You have to wipe your hands with a sterile towel and wear a sterile pair of gloves. Vascular access is of 3 types: intravenous, intraarterial, and intraosseous. So whether it's in children or adults, the basic approach is the same. So first we will talk about the intravenous access. So again, there are a couple of basic principles you need to know. You have to always use the patient's non-dominant hand. This is to minimize the effects on hand function. And also you need to have a good knowledge of venous plexuses in your hands and feet. If you can remember your anatomy, there is a venous plexus in the dorsum of the hand, then the flexure aspect of the upper forearm, and also dorsum aspect of the foot, right? The other thing is you have to ensure satisfactory peripheral perfusion. If the perfusion is not good, then you have to think of the other avenues without wasting all the peripheral veins, right? The other thing is you have to first try the distal veins and then move proximally, because if you start centrally and if you puncture the vein, you will not be able to use the distal part of the same vein subsequently. There are certain areas that you should try and avoid. What are those? For example, the veins over the joint flexures, as in you can see in this picture, right? Then junctions of 2 veins. Then the veins close to the arteries and deep lying vessels. For example, the median cubital vein in the elbow, which is close to the cubital artery, as much as you have to sort of try and avoid. And then the visible veins, but which are not palpable, not good for the cannulation. And also avoid bigger veins initially. For example, the veins like great saphenous vein and cubital fossa veins, because these veins should be preserved for the venous access for PICC lines or central lines or for difficult blood sampling. So better not to use at the beginning. There are few contraindications for the peripheral use. So what are those? Sodium bicarbonate, inotropes like dopamine and vasopressins in high concentration, especially calcium gluconate, high concentration dextrose, anything above 12.5 should not be used peripherally, thiopental, and antibiotics like clarithromycin. So all these medications are having a higher osmolality than the plasma, so they can cause irritation, venous necrosis, and sloughing of the skin. So this is actually not an uncommon event in the past, and rarely amputation of the limb also has happened in the past, and there have been instances leading to legal implications too. So if you happen to give these drugs through a peripheral line, you have to give it slowly with adequate dilution. So prior preparation is important for before any procedure. So keep the necessary equipment at your hand before starting the procedure. So what you need? You need to have the peripheral IV cannula of various sizes, because you really don't know about the size of the veins of your patient. So have different sizes, right? Then local anesthetic agents, syringes of various sizes for flushing purposes, to withdraw blood for investigations and those things, right? And then there should be a suitable tourniquet, things like splints, hypoallergic plasters, tegaderms, bandages, pair of scissors, and also bottles to collect blood. With regards to the IV cannula, that should be in good quality. What do you mean by good quality? You should be able to insert it easily, and also it should permit optimal flow rates, should have injection port, and should have a long cannula life. So with practice, you will be able to come to this judgment whether it's a so-called good cannula or not. There are various gauges in cannulae. As you can see, when the size of the cannula increases, the gauge decreases. There's a color code to make the matters easy. So the cannula, the purple and yellow cannula are for newborns, blue for pediatric patients, pink, green, and white for adults, and gray and brown for adults who need rapid blood transfusions. So let's move on to the procedure. Pain management is very important. There are pharmacological and non-pharmacological strategies to minimize pain. So when it comes to the pharmacological strategies, there are 2 drugs available. We have EMLA frequently used in our country. The other drug is Amitop. So there are clear differences between the 2. For example, the onset of action is rapid with Amitop, and also it causes less vasoconstriction. Before using them, it is always better to mark the vein on the skin with a marker pen, because with the vasoconstriction, sometimes veins can get lost and faded after the application of the local anesthetic agent. So mark it before you applying the Amitop or EMLA. How long does it take to get the action? It will take about 20 to 30 minutes. So it is important to apply them well in advance, and also in more than one area, and in more than one area as well, right? So with regards to the pharmacological strategies, these include various methods to distract the child. You can ask the mom to speak to the child, show something like soap bubbles, toys, and moving animated clips. The best equipment these days would be the smartphone, right? So actually in the Western countries, there are designated people to do this job using the kind of a play therapy. The next important thing is the getting the vein prominent. I'm sure you would have tried some of these steps during the clinical practice. So what are those? You can ask the patient to clench the hand and try to pump some blood. Or you can ask allow the arm to hang over the bedside, keeping at a level below the heart. The warm extremities by wrapping with warm towel or dipping it in warm water, especially useful in newborn. You can sort of tap on the vein lightly. The other thing is you can have create a pressure by applying a tight tourniquet or with your hand grip to obstruct the venous flow. But make sure that it's not too tight to obstruct the arterial flow. So once the vein is prominent, then you have to clean the area with betadine and alcohol soaps. Then select the straight section of the vein, as I told you before. And you should not use the kind of tortuous veins, right? So when you're puncturing the skin, do it about 2 to 3 millimeters away from the vein. Then go through the subcutaneous tissue to prick the vein. So you have to sort of prick the vein subcutaneously. Keeping the needle under the skin, right? So this skin layer will act as a barrier and prevent leakage. So you should not puncture the vein from the top. So remember, cannula should not occlude the vein completely. So you have to select the proper cannula for the patient. How do you know that you have entered into the vein? You will see the presence of blood in the flashback chamber. The moment you see the blood in the flashback chamber, you need to insert the cannula a little further, and then only you have to remove the stillet. And also you have to make sure there is a free flow of blood from the cannula before taking the stillet out. Let's move on to some problems you may face during the cannulation. Think about this instance. With the insertion of the cannula, blood, you will see the blood in the flashback chamber. Now you advance the cannula and remove the stellate. So once you remove the stellate, you will realize the flow has stopped. What would have happened? Look at this picture. You will notice that the tip of the stellate is pointing about 1 to 2 millimeters beyond the cannula proper. So what would have happened in this case was once the stellate has punctured the vein, blood would have come through the cannula, but unfortunately the cannula, the catheter is still outside the vein. So that's why when you pull the stellate out, the blood flow stopped. So how to overcome? You had to reinsert the stellate and advance the cannula further before removing the stellate. Second problem is with the insertion of the cannula, you will again see the blood in the flashback chamber, but upon advancing, you had realized the blood flow has stopped. So what would have happened here? If you look at the picture, you can see the cannula has gone through and through. So no blood flow. When you are sort of removing the stellate, you won't see any blood flow, right? So if you advance it again, there is a possibility that it can go to the same false passage. So how to overcome that? What you have to do is, with the free flow of the blood from the cannula, you better to attach a 5 ml syringe which is filled with saline, and then advance the cannula while flushing the vein. So this will open up the vein and allow the cannula to stay in the vein. The proper anchoring is very important. Not like in the first picture. You have to do it properly. Otherwise, the whole effort that you took so far may be in vain. So when plastering, you have to make sure the cannula tip is clearly visible. You can see it in the second picture, right? This is in order to identify the early signs of infection or leaking. Then you have to first put a plaster across the cannula, then on either side of the 2 wings. After that, you can apply a tegaderm over it. Always use hypoallergenic plasters in the children, not the sticky plasters. Splinting is generally discouraged as it can deprive them with hand functioning. So after insertion, always you have to check for the patency of the cannula with a flush. And in children, it is always advisable to use a LS connector. So there won't be any additional weight on the cannula. So all the syringes can be connected to the LS connector, so less chance of pulling it out as well. The other important thing is you have to always record the time and date of insertion. And you have to resite the cannula every 48 to 72 hours, even though it's functioning, to prevent venous thrombosis or infection. So what are the complications of cannulation? You can get things like hematoma formation. Then, as I told you before, infiltration of the subcutaneous tissue with IV solution can cause vasospasm, ischemia, gangrene of the distal extremity, right? So during forced flushing, you can cause air embolization or clot embolization. Then accidental injection into the artery can happen. And the other thing is, and most common is the phlebitis and infection. So all these are actually iatrogenic. So how do you identify blocked cannula? You can do it clinically. When you are flushing, giving a flush, you will feel a resistance. Or if you are using a syringe pump, there are 3 indicator pressure bulbs to show the level of resistance to flow. So in whatever the way, if you are suspecting a block, you have to flush the line with heparinase saline to liquefy the clot. So if the line is still not working, you have to resite the cannula. Little bit about the external jugular vein cannulation. So this is a good vein to access in collapsed patient, but you need experience to do this. So all what you have to do is place the child in about 15 to 30 degree head down position, keeping a pad under the shoulders. Then you have to turn the head away from the site of the puncture and then clean the skin as usual. Then you can identify the external jugular vein when it passes over the sternomastoid muscle at the junction of its middle and the lower third. Then you have to ask your assistant to place his or her hand finger at the lower end of the visible part of the vein, just above the clavicle, which is shown in this picture. So this will stabilize the vein and also will compress it so that the vein will remain distended. Then entering into the vein, anchoring, everything is as same as for the other veins that we discussed, but we have to ensure that there shouldn't be any air bubbles, before attaching the giving set. The rare venous access sites are scalp vein cannulation and venous cut down. Actually, they were in practice when we were students or trainees, but nowadays with the ultrasound guided cannulation, it's not really in practice. But if you happen to go to a periphery where the ultrasound, the facilities are not freely available, you may have to use these things as well. So about the scalp vein cannulation, the veins that you can select are the frontal, superficial, temporal, posterior auricular, supraorbital and posterior facial veins. You can use a butterfly set, fix it saline, filled with saline for flushing, right? And venous cut down is commonly done at the greater saphenous vein at the ankle. Umbilical venous access, it is very commonly used in newborn, especially preterms, and it's a kind of a central venous access. I think you all need to know about this, right? So it's helpful in delivering drugs, parenteral nutrition, and it can avoid multiple peripheral cannulation if you have the umbilical venous access. And it's also used in the emergency vascular access for resuscitation of infants when they are in the collapse situation, and also for exchange transfusion. So if you can remember the anatomy, the umbilical vessels, there are two arteries and one vein. The umbilical vein is the one which is sort of placed more caudally, and it has a kind of a slit-like appearance, whereas the two arteries are like cords, right? So there's a formula to calculate the length, but in the emergency, what you have to you can just measure it on the body of the baby, directly taking the measurement from the cord to the base of the sternum, and then at the cord stump length. So generally we use the catheter size is 5 or 3 femto. And after insertion, unless it's an emergency situation, you have to always confirm by taking an X-ray. The level ideally has to be at the level of T10 or T8 or T9. The anchoring is a bit different here. You can see, you can sort of apply a kind of a bridge-like thing. So that will keep the umbilical catheter in place. Femoral vein or internal jugular vein access is done through ultrasound guide. This is a very safe and effective way of getting into the central venous access. So if you have to remember, but only thing is you have to remember that central venous access is not without dangers, especially in an unexperienced hands. A bit about PICC lines, peripherally inserted central lines. So the catheter is inserted through the veins in the arm or femoral vein. So there's a special catheter for this. After the insertion, you have to again get an idea about the level. The tip of a catheter should be just outside the right atria, right? So we have to take an X-ray. So butterfly cannulation. So what are the indications to obtain blood cultures without IV cannulation? Also to obtain blood samples for investigation. Sometimes you may be given once-day medication, especially as outpatient basis. So for these purposes, you can use the scalp vein cannulation. As you can see, there are different gauges and lengths with the color code. So let's move on to the intraosseous access. So this is indicated if other attempts of venous access have failed, especially if there's a failure to give IV access in 3 attempts by an experienced person, you better to move on to a intraosseous access in an ill patient, right? And this is definitely recommended in a collapse patient or especially in cardiac arrest. So intraosseous needle can be used manually or with the easy IO drill. So this drill is a kind of a powered device that will enable rapid insertion of the intraosseous needle. So this procedure is less painful due to its rapidity. So can be used even in the conscious victim. IO needle manually can be used only up to the age of 8 years, but with the easy IO gun that can be used in any age. So needles again come in 3 lengths with a color code, but they all are 15 gauge. The length of the needle will depend on the size of the patient and also the insertion site. So location is same for the manual insertion as well as the drill. The commonly used sites in children are the proximal tibia and the distal femur. So in the tibia, it's the anterolateral surface 2 to 3 millimeters below and medial to the tibial tuberosity. And in the femur, it's the anterolateral surface 3 centimeter above the lateral condyle. So you have to first stabilize the insertion site with your non-dominant hand and then firmly hold the drill or the manual needle with your dominant hand, right? So the position of the needle tip at the point of insertion has to be perpendicular to the long axis of the board. So with the manual needle, you have to advance the needle with a moderate pressure with a kind of a through and fro rotary movement until you feel sudden loss of resistance. With the drill, you have to just squeeze the trigger, the trigger button while applying steady downward pressure. Again, you will just feel a loss of resistance when you enter into the marrow. So it is important to point the needle slightly away from the joint space, because otherwise that there is a possibility that it will damage the growth plate. Right? So how to anchor the IO needle is shown in this picture, because it doesn't have a kind of a wing to stabilize. So you had to sort of put an artery forceps, and the forceps only has to be sort of fixed into the patient. So you can give any drugs or any fluid that are given in peripherally through the intraosseous needle. And also you can do the basic investigations as well. But only thing is you have to mention that it is from a marrow sample. Otherwise, the interpretation will be different. Little bit about bleeding for sampling. In children, it is difficult to draw blood directly into the syringe. So either you have to collect drops of blood straight from the needle, or you can use a butterfly catheter. So the broken needles were used in the past, but this is not recommended now, because there have been instances the needle has got lost in the vein. So instead, there are special needles that you can see here for this purpose. But in our country, in the government sector, we don't have it. But what you can do is you can sort of you can use the scalp cannula, and you can cut the plastic portion of the butterfly cannula and use the needle for the blood sampling. For capillary sampling, the sites that we are using are the heel, fingers, and the earlobes. So when you are doing the heel prick, you have to take the midpoint, take the point midway between the edge and the midpoint of the finger, right? Then always better to use the middle finger, and you should avoid excessive squeezing. So these are especially useful for either capillary blood gases or CBS monitoring. So with regards to the heel prick, this is especially useful in newborn. The area to puncture are shown in the diagram. You have to draw two vertical lines from the big toe as well as the junction between the little and the fourth toe. And the area to puncture is the lateral aspect of the two lines, which is marked red in this picture. The middle part is not recommended because it's a very sensitive area, and also it's close to the underlying bone. The other two pictures show how to hold the foot for the capillary sampling, and also how to collect blood into a capillary tube. Moving on to the arterial cannulation, what are the indications? You may have to monitor the arterial blood pressure, obtain blood sample for blood gases, or to calculate the cerebral perfusion pressure. So it should be performed in sites where there is a good collateral circulation. The places that we can use are either radial or ulnar vein, ulnar artery, then the posterior tibial, dorsalis pedis, femoral arteries. Those are the ones that we can use for arterial cannulation. So in this picture shows how to perform the Allen's test to demonstrate collaterals. So all what we have to do is you have to squeeze all the blood from your hand towards the forearm until the hand is really pale. Then you have to occlude both the radial artery as well as the ulnar artery at once. And if you are going to pick the radial artery, you have to sort of occlude that and see, remove the other one on the ulnar artery and see whether the collaterals are functioning, in which case the hand will look pink again. Vein weavers, again, very useful in cannulation in children. So they emit a kind of a infrared light, which is absorbed by the hemoglobin in the blood. So the vessels are clearly visible, but they have a limited use because they are not helpful when the circulation is collapsed. So that is the situation we need some kind of additional help. But if the circulation is collapsed, as there's no blood in the vessels, you won't see the vessels very clearly. And also it will give only a two-dimensional view. So you don't have any judgment about the depth of the vein. However, they will be useful when all the superficial veins are exhausted or damaged and you need to get into a deeper vein, then you can use the vein weavers. What is shown in the right side is the cold light. Here, actually, you can get some idea about the depth as well, especially again useful in newborn when you are putting long lines or arterial lines. Yeah, so those are the few things, a few important things with regards to the vascular access. Any questions? So I think this is the good time for you to practice. The internship is a good time for you to practice the cannulation because you will get ample of you know, in our setup, actually, the nurses are doing it, but only thing is in the difficult cases, they will call you. So if you are not having good skill, hands-on skills, you will find it difficult to put the cannula. So practice during your internship. So you can move on to the next lecture. Chamodi.
Thank you very much, Madam, for the detailed lecture. So if you all have any questions, we can take 5 minutes to a couple of minutes to answer those questions. You all can unmute and ask, or you can use the chat box.
Any questions? Everything clear?
So if there is no questions, we go to the next lecture. Thank you very much, madam. So next lecture is on oliguria and AKI by Dr. Inoka Pereira, consultant pediatric. So
I'm Dr. Inoka Pereira. I'm Dr. Inoka Pereira, pediatric nephrologist from LRH. I'm going to talk to you about oliguria and acute kidney injury over the next 30 minutes because it's a very important topic, and as new doctors who are starting your medical career, it's very important that you know how to handle, how to evaluate and what to do when you come across a child with oliguria and acute kidney injury. Because you all are the people who will first see patients, you will be the first contact. You will first see the patients, you will be the first people who will be starting initial treatment of any child with reduced urine output. Therefore, it's very important that you know what to do in a situation where the child comes with reduced urine output. So my talk will briefly touch on normal functions, a little bit about normal functions. I like to explain some definitions and also talk about risk factors of developing acute kidney injury, how to diagnose, the management and prevention of acute kidney injury. Right. So I'm sure you would have learned everything about the anatomy and function of the kidneys in your during your medical school days. But just to recapitulate, the kidney has not just one function; it has many very important functions that are essential for maintaining life. Starting with maintaining intravascular volume by way of glomerular filtration and tubular reabsorption of water. Kidney is also responsible for maintaining acid base and electrolyte balance of your body. And it also is the most important organ when it comes to managing blood pressure. That's why any disease associating any renal disease is usually associated with a raised blood pressure. It's also important in erythropoiesis because it produces the hormone erythropoietin, which is essential for red blood cell production. And it is also important for calcium and phosphate metabolism. So it's involved in the bone metabolism as well. So if you look at the nephron, which is the functional unit of the kidney, it has several parts, you know. So the glomerular is the initial part. This is where the filtration of the plasma takes place by ultrafiltration. Fluid is filtered into the blood vessel, and which is followed by the proximal convoluted tubule, which is a very important part in the when it comes to the nephron, because this is where the obligatory fluid absorption take place. That is, irrespective of the volume status of the patient, there will be water absorption, as well as most of the important minerals are absorbed from the proximal tubule, including your sodium, potassium, chloride, calcium, phosphate, magnesium, and it's also responsible for excreting bicarbonate. So any problem, any insult to the proximal tubule can lead to derangement in absorption of these very essential minerals from the body and into the body. This is followed by the loop of Henle, which has a thin descending and an ascending segment. The ascending segment is impermeable to water, and then followed by the distal convoluted tubule, which again is a very important area where there is tight regulation of water absorption under the influence of antidiuretic hormone takes place. So in a child whose volume is depleted, or if there's hypovolemia, the fine regulation of water absorption takes place in the distal convoluted tubule. In addition, very important mineral sodium absorption takes place, potassium excretion, hydrogen ion excretion. Those important, the fine regulation of acid-base status also is happening in the distal convoluted tubule. So the proximal tubule, your loop of Henle and thick ascending loop of Henle, distal convoluted tubule, and which drains into the collecting duct. So there are several nephrons draining into the collecting tubule, which again opens into the renal pelvis. So if you consider the renal corpuscle, it's very important to know the structure of the renal corpuscle, which consists of a glomerular capillary tuft and a Bowman's capsule. Now, if you look at this diagram, the afferent arteriole brings in blood into the glomerular capillary tuft, and the blood leaves via the efferent arteriole. If you look at the diameter of these two arterioles, the afferent arteriole's diameter is larger than that of the efferent. This is a very important structural adjustment, because when blood flows into the capillary tuft here, and it leaves via the arteriole which has a lesser diameter than the afferent arteriole, the pressure inside the glomerular capillary tuft rises. This is the driving force that maintains the glomerular filtration rate. So any disturbance in these high pressures inside the glomerular capillary tuft can reduce the glomerular filtration rate. So what are the insults that can affect the reduce the pressure inside the glomerular capillary tuft? One is if the afferent arterial dilatation is affected, the diameter is reduced, or if the efferent arterial diameter is increased, then the pressure inside here can drop. So that will affect the glomerular filtration. So certain medications like non-steroidal anti-inflammatory drug, which is a prostaglandin antagonist, can affect the diameter of the afferent arteriole. Likewise, angiotensin converting inhibitors and angiotensin receptor blockers, which has an anti-renin action, can also dilate the efferent arteriole, which again leads to reduction in the pressure inside the glomerular filtrate. This is very important in the mechanism or the pathogenesis of acute kidney injury. So you need to remember there are certain age changes in the kidney. When kidney development starts around 5 weeks of gestation, by 30 weeks of POG, the nephrogenesis is complete, and we get about 1 million glomeruli per kidney. So the important thing here is, in a preterm baby, preterm babies will not be having their optimum number of nephrons. So that can affect, so if any insult to them in the form of birth asphyxia or reduced perfusion or any toxic injury can easily push them into developing acute kidney injury. So that is a very important thing to remember, especially if you are working in a neonatal unit. The preterm babies are at increased risk of developing AKI due to this factor. Then the plasma creatinine level reflects maternal level at birth, because in utero, the baby's creatinine is removed from the maternal circulation. So at birth, when the cord is clamped, the maternal circulation is disrupted. The baby's kidneys are immature, so it's unable to excrete creatinine efficiently. So during the first 48 to 72 hours, if you check the blood, the baby's creatinine will be the same as the mother's level. So the ideal level, if you want to check the creatinine level of a newborn baby, is to do it after at least 48 hours. In the event, if you have to do say on day 1 of life, if you want to do a creatinine level and you find it high, you always repeat it after about 24 hours, then you will see that it improves. So glomerular filtration rate, as I said, in preterm babies is very low. It's about 10 to 15. In a term baby also, it's still low. It's about 15 to 20. And the adult level is reached by about 2 years of age. This is again very important in our management and also knowing the pathophysiology of acute kidney injury, that newborn babies, small infants can easily be pushed into acute kidney injury. And also when we administer fluids also, it is important to bear in mind that and the short length of the tubule. As the baby grows older, the tubules will mature and lengthen. So the maximum concentration ability will reach about 1 year of age. It's important to know how to calculate your glomerular filtration rate, which is done by using the Schwartz formula, which I'm sure you know, and it's a useful formula to have on hand, because you will have to know the GFR in certain situations, and you might have to, for example, if you want to adjust your medication according to the GFR, you need to know this. So it's calculated by K, which is a constant, multiplied by height in centimeter, divided by creatinine in micromoles per liter. And K varies according to age group. So if you know this by heart, that's fine. If not, if you want to do most centers, most hospitals in the developed countries use K as 40 for everybody. So if you want to roughly estimate, use K as 40 and height in centimeter and creatinine in micromoles per liter. So look at the definitions. What is oliguria? Oliguria is defined as urine output less than 0.5 milliliters per kilogram per hour in infants and children. It's below 1 ml per kg per hour in neonates. Also remember that in acute renal failure, not everybody is oliguric. There are situations where the patient's urine output is maintained above 1 ml per kg. It's called non-oliguric renal failure. In fact, patients can be polyuric. They can be having more than 4 ml per kg per hour of urine. For example, in the case of aminoglycoside or radiocontrast-induced acute kidney injury, and also in leptospirosis, the urine output is maintained. So in such patients, actually, it's easy for us to manage because there is no risk of developing fluidopathy.
Okay.
Hello. Right. So acute kidney injury versus acute renal failure. The term acute renal failure has been replaced by the term injury because you don't wait until the kidney fails. If you wait until an organ fails, there's very little you can do. The patient can even die. So we need to identify before the patient moves to a renal failure. That's why it's important to identify them when the kidney injury occurs. So that's why the last few decades, the replaced by injury. What is the impact of acute kidney injury? It increases because studies have shown in PICUs, the mortality rate can be about 30% when there's acute kidney injury compared to not having kidney injury when it is about 2.3%. It increases the need for ventilatory support. There is AKI is associated with longer hospital and ICU stays. The patient may not recover. There is a risk of non-recovery. The kidney function may not recover at all. And there is a risk of developing hypertension and proteinuria later on with development of progression to see chronic kidney disease. And also, what about the cost of care? Dialysis and ICU stays and prolonged ICU stays is associated with a cost, isn't it? It will involve in a very high health budget. So because of that, it's very important that we identify and manage these people early. So the epidemiology of pediatric acute kidney injury has changed over the years. Incidence of AKI in hospital children is now rising alarmingly. In PICUs, it's about 10 to 35%, and it's higher among those receiving inotropes and ventilation. And incidence among infants and children undergoing cardiac surgery is as high as 30 to 50%. And it's common in not only among PICU patients, but also in children in wards as well, especially if they are receiving aminoglycosides and multiple other nephrotoxins. Right. So what are the etiology of pediatric acute kidney injury? In the developed countries, the etiology has shifted from primarily glomerular disorders such as acute glomerulonephritis, hemolytic uremic syndrome into hospital-acquired kidney injury due to nephrotoxins, post-surgical, post-transplantation, and malignancy. But in developing countries, dehydration, sepsis, and HUS still remains very important causes of acute kidney injury. So it's very important that in your day-to-day practice, you identify children at risk of developing acute kidney injury so that you can take preventive measures early. So who are these children at risk, especially neonates, more preterm, more than term, as I explained earlier. Children with congenital heart disease who have heart failure because they are cardiac output is low, the renal blood flow is low. They are also on ACE inhibitors, usually captopril, as I mentioned earlier, which can reduce the glomerular filtration. Then those on PICUs, every child who is admitted to PICU is at risk of developing AKI, especially if they are ventilated and need inotropic support or surgery. Those receiving nephrotoxic medication, and especially children having pre-existing renal disease, if they are subjected to various fluid depleting conditions, or if they are subjected to nephrotoxic medication, they are at risk of developing AKI. So be careful when you come across this kind of patient. So how do you diagnose? There are more than 30 definitions which have been used in the past, and most of them use creatinine, which is a poor biomarker, which varies with age, race, gender, diet, and muscle mass, and other things. And the up to 50% of the kidney function has to be lost before the creatinine even begins to rise. So we will not be able to identify a patient with kidney injury at the beginning. So, and it does not identify the etiology or the severity of kidney injury. So 3 main definitions have been used when it comes to diagnosing AKI in children. That is Rifle criteria, Akin and KDIGO criteria, and I've learned all these in medical school. Each one have their own advantages and disadvantages. And Rifle criteria is more sensitive in identifying AKI, whereas Akin is more specific in identifying AKI. Some needs calculation of GFR, so they are not really practically very useful. So most people nowadays use KDIGO guideline because that is the latest. In any of all 3 conditions, classifications have common factor, that is they describe the progression from mild kidney injury to severe renal failure. That is the importance of these diagnostic criteria. So what is the etiological classification? You know, pre-renal, intrinsic renal, and post-renal. I'm not going to spend a lot of time on that. There are a whole list of various lists in your textbook. So it's important to know evaluation from pre-renal to intrinsic renal injury. In a child who has hypovolemia, the renal blood flow is reduced. This can lead to pre-renal injury. Here, the structure of the kidney is normal. So during this, when this happens, there are a lot of compensatory mechanisms. When the renal blood flow is reduced, the kidney will try to auto-regulate its blood flow by producing chemicals like prostaglandin, angiotensin 2, nitric oxide, endothelin, various chemicals. It tries to maintain the blood flow. So if you restore the blood flow at this point, you can prevent further progression, which is injury to the renal blood. When if blood flow to the kidney is not restored in time, the pre-renal injury will lead to intrinsic renal injury, where the kidney structure is damaged. So this is not immediately reversible. The kidney has to undergo repair and remodeling, which can take days, weeks, or months even. So this is the situation that we need to avoid. We identify children at risk of kidney injury, acute kidney injury, and try to prevent them from progression from pre-renal injury to intrinsic renal injury by doing various measures, especially maintaining their renal blood flow. I will explain as I go on. So management of acute kidney injury, there is no specific treatment at the moment. Up to date, the management involves around conservative management versus renal replacement therapy. So conservative management include maintenance of fluid and electrolyte balance, preventing any life-threatening complications like pulmonary edema and hyperkalemia, managing hypertension and acid-base status. Management cannot go on forever. It will maximum few days. At some point, if the kidney does not recover, we will have to resort to renal replacement therapy. So while undergoing conservative management, we daily assess the patient by monitoring whether we need to start renal replacement therapy at any given time. So let's look at a case. 13-year-old previously healthy girl was admitted to a local hospital with a history of very high fever and cough for 3 to 4 days. She has vomited about 10-15 times the previous 24 hours. She was treated by a general practitioner with paracetamol, domperidone, comaciclab, and given ORS with poor tolerance due to vomiting. She has passed only a small amount of dark color urine twice the previous day and has not passed urine for 10 hours when she got admitted. There are no other systemic features. She frequently is an active girl going to school. This is a true story actually. She bathes in the river frequently. On examination, she was found to be very dehydrated. Her pulse volume, low volume pulse with a tachycardia. Blood pressure was low, 85/50, and there were bilateral crepitations on the lungs. This is the kind of typical case you will get in your day-to-day practice. So how do you evaluate the patient? There are no shortcuts. You have to take a history exam and do a comprehensive examination. What are the important things you look in the history when evaluating a patient? What is the form of, has there been any form of fluid loss in the form of diarrhea, vomiting, any excessive sweat, especially in warm days like this? Has the child been having polyuria, polydipsia? It could be dehydration again. What is the color of the urine? Is it yellow? Is it reddish Coca-Cola color, which can indicate a glomerulonephritis? What is the urinary stream? A poor stream in a neonate can be due to blood outlet obstruction. Has there been diarrhea associated with blood and mucus, which can indicate hemolytic uremic syndrome? Are there systemic features? What is the drug history? Has the child received any nephrotoxic medication? What is the past medical history? Is the child having congenital heart disease and heart failure? Was he a diagnosed patient having congenital abnormality of the kidney and urinary tract, birth asphyxia? River bathing indicates leptospirosis. So when you examine the body weight, volumes, you assess the volume status, feel the peripheries, capillary refilling, and feel the anterior fontanelle, whether it's down or up. Check the mucous membrane for any signs of dehydration. Look for any systemic features such as rash, joint swelling, and edema. Your system examination check the respiratory rate, heart rate, and blood pressure, and record these because they are all very important when you want to assess the child for any response to your treatment. Tachypnea can indicate heart failure, metabolic acidosis, could be due to bronchial asthma or pneumonia. Tachycardia usually can be due to hypovolemia. Elevated blood pressure, don't evaluate this in isolation. Elevated mild to moderate elevation of blood pressure with cold peripheries and tachycardia indicates hypovolemia, whereas moderate to severe rise in blood pressure with warm peripheries can be due to hypervolemia, such as in acute glomerulonephritis. Feel the bladder. Can you feel the bladder? Can you feel the bell of the kidneys? It can be due to bladder outlet obstruction in a baby. So are there any risk factors like congenital heart disease, pre-existing kidney disease, any nephrotoxic medication? As the baby is it a preterm baby? So these are the things that you need to consider when evaluating the patient. So after taking your history and examination, you need to ask 3 questions. What is the volume status of this patient? Is he hypovolemic, euvolemic, or showing signs of intravascular volume overload? Now, based on our history, our patient seems to be in hypovolemic, isn't it? He has been vomiting many times. There is tachycardia, cold periphery, low blood pressure. So she is probably hypovolemic. Are there any life-threatening conditions? Is the child having pulmonary edema? Is there hyperkalemia? Is there severe hypertension, severe acidosis? So you might need to do your blood test. Pulmonary edema, if there is edema, anuria for some time, basal crepitations, reduce your saturation can indicate whether this child is having pulmonary edema. What are the most likely etiologies that causes acute kidney injury? Because we have to address the etiology. Our patient is probably having a pre-renal element due to vomiting. He could be having intrinsic renal illness due to bacteremia, bacterial toxins, sepsis. She could be having leptospirosis because she frequently bathes in the river. So there can be several etiological factors when you see a patient with oliguria and urea. So how do you assess the fluid management? How do you do the fluid management? It depends on the volume status of the patient. If you find the patient hypovolemic, your first priority is after establishing cannulation and you take your bloods is to fluid resuscitate the patient with 20 ml per kg normal saline given over 30 minutes. And then you reassess. You might have to repeat if the volume is still not adequately resuscitated. So with adequate resuscitation, your tachycardia should improve, blood pressure should improve, peripheral circulation should improve. In a child who is in PICU, you might have to think of starting inotropes if there is no response to fluid boluses. Are you going to give any colloids? Are you going to, this is so in any child with hypovolemia, you do a fluid resuscitation. And usually if there is no other risk factors, adequate fluid resuscitation will be followed with diuretics. Patient will start passing urine in 1 to 2 hours. If that is the case, you can give subsequently maintenance fluid. You have to correct any deficits due to any fluid losses. And if there are any ongoing losses, replace them as well. Most people forget the last 2, only give maintenance. Sometimes that is not enough. So think about correcting any deficits and replacing ongoing losses. But what happens if the child is euvolemic? What are you going to do then? You can give a fluid challenge with 10 to 10 ml per kilogram of normal saline given over 1 hour, along with a dose of furosemide 1 to 2 milligram per kg IV bolus. And most patients, you generally respond with diuresis, then you follow this pathway. However, if there is no improvement in urine output after 2 to 3 hours, you might have to consider 100% of the previous losses that include urine output, insensible loss, and any other losses. So if your patient is volume overloaded, showing evidence of pulmonary edema, high blood pressure, basal crepitations, lung signs, then you need edematous, then you cannot give fluid. You need to restrict. How much you restrict is you replace a certain percentage of your losses depending on the degree of volume overload. You can give 2/3 of your previous losses, or half the previous losses, or sometimes you may not. If in a very severely volume overloaded patient with reduction in oxygen saturation, you may even give insensible loss at the beginning. And then give furosemide. Some patients are diuretic responsive. You can give 2 to 4 milligram per kg of this slightly higher dose of bolus, or start an infusion. And then you have to consider, are you going to should we start renal replacement therapy at this point? So your initial and subsequent fluid management depends on the volume status of the patient. That has to be evaluated on a daily or twice daily basis, because the volume change can change. Volume status can change. A hypovolemic patient whom you have resuscitated and become euvolemic and decided to manage the conservative pathway with no urine output, to keep on going, giving fluid, you might end up with volume overload. So you daily assess the patient for volume status. Then you send your basic investigations. If the patient has even the little bit of urine, if you pass a catheter, you might find 5 to 10 ml of urine. Don't discard that. That gives a lot of valuable information. Send that for urine full report. It will show you that there's proteinuria, red blood, hematuria, CAS, that there's any evidence of pyelonephritis. Send it for culture. If you have the facility, you can do serum creatinine osmolality. I doubt whether these will be probably not available, and they're not that essential for our management. To do your blood investigations, urea, creatinine, do a venous blood gas. No need to do arterial blood gas unless there is concerns regarding ventilation. You do your corrected calcium, phosphate, alkaline phosphatase, check the albumin. In certain cases, you might have to do the liver functions, SGPTOT as well. Then, of course, you will do your full blood count, blood picture, culture, ESR, CRP. Those are the usual basic investigations. So at the earliest convenience, you must look at the do an ultrasound scan just to look at the kidney. This child could be having a pre-existing congenital kidney disease which has not been previously diagnosed. Usually, a normal kidney with acute kidney injury will be very echogenic and large. So look for obstructive features like hydronephrosis, hydroureter. Trabeculated bladder with dilated posterior urethra will tell you that you are dealing with a baby with posterior urethra valves. Right. So when you get your investigation, there are certain clues you concentration. The rise in blood urea is more than the rise in creatinine. If you have the facility to do urine osmolarities, urine will be very concentrated. The kidney is trying to conserve water by absorbing sodium, so sodium excretion is really low. As opposed to intrinsic renal failure, the rise in serum creatinine is more than the rise in blood urea level. That will tell you that you are dealing with a there is established renal failure, or intrinsic renal failure, intrinsic kidney injury. So our case continued. Despite volume ordered resuscitation, this child still looks dehydrated, still a bit tachycardic. Pulse volume has improved a little bit, blood pressure, with moderate volume, and the mild improvement in blood pressure. Earlier, systolic was 85, now it's about 95. So how do you proceed? So you catheterize the patient and you find about 10 ml of urine, which you send for investigation. You can give another normal fluid bolus. With that, the blood pressure and the tachycardia improve. At this point, because of the significant vomiting, it was decided to give maintenance fluid for along with a bolus of furosemide for about 6 hours, just to ensure that the blood pressure and the renal perfusion is maintained. And this child was started on IV antibiotics to cover the respiratory tract infection and possible leptospirosis. So how do you monitor this child? You need to check the weight daily. It's extremely important. Sometimes in a fluid overloaded patient, you will have to check the weight twice a day, monitor the vital signs and the neurological state. You monitor it, decide on a frequency. In a very sick baby in a PICU, you will do it hourly. In a ward patient, less frequently. Then you will have to do a strict fluid input and output chart. Catheterize in a small baby, you might have to weigh nappies if you don't catheterize. And then monitor the urine output at least 3 hourly. In a catheterized baby, you have to instruct the nurses to monitor the child's urine. If there is any urine, check it every 3 hourly and calculate it milliliters per kg per hour. And then you have to look for life-threatening conditions every day. Look for hyperkalemia, look for pulmonary edema, look for any severe hypertension. So you do your daily investigations, including the renal functions, the gas, and evaluate whether we continue to manage this patient conservatively or are we going to start renal replacement therapy. This assessment has to be done every day. So because we cannot go on, as I said, manage conservatively for a long period of time. So this child remained anuric. Her blood pressure and circulation was restored. There was no hypovolemia during the next 2 to 3 days. There was no evidence of pulmonary edema. So how much fluid did we give? We only replaced the losses. Urine output, she did not pass any urine, so we couldn't give any include this into the fluid regime. We only gave insensible loss, which is calculated at about 300 to 400 milliliters per square meter per day. You give higher amount if there is fever, because if in a pyrexial child, the insensible loss is high. We discontinued the furosemide because there was no response. And antibiotics were continued. Her lung signs got better. And we continue to manage the patient conservatively while monitoring with daily monitoring and daily investigation. On the 3rd day of illness, this is the stage. The patient is conscious, rational. There is still no urine output. Her blood pressure pulse is 90. Now the blood pressure has started to rise a little. And she is slightly tachycardic, and there were a few basal creps. Her investigations came as urea has, during the following few days, the patient was monitored with daily investigation. The urea and creatinine was slowly rising. And by the 3rd day of illness, on admission, her urea has come up to 36 millimoles. The upper limit is about 8. Creatinine has gone up to about 136. There's low sodium, hyperkalemia. So these are the blood gas results. Hemoglobin has dropped a little. So what are the problems that we have to deal with? There is hyperkalemia, hyponatremia, uremia, metabolic acidosis. There's some evidence of pulmonary edema. If you want to confirm, you can do a chest X-ray. What do we do now? We continue to manage conservatively, or do we consider starting renal replacement therapy? So I'll just deviate and describe the management of hyperkalemia. So hyperkalemia can lead to cardiac arrest or arrhythmias. So you need monitoring of ECG monitoring if the plasma potassium is more than 6. So typical ECG findings are prolonged PR interval, prolonged QRS complex, and tall peaked T waves. If you see these changes, that include that the hyperkalemia, the child could be having at risk of developing arrhythmias. So how do you treat? You restrict potassium intake in your fluid and drugs. Definite treatment is removal as urine or by dialysis. Until that happens, we need to do holding measures until definite removal is taken place. How do we do that? By shifting potassium inside the cell to stabilize the myocardial membrane potential. So what is the emergency treatment? If there are ECG changes, we need to stabilize the myocardium with 10% glucose, 0.5 ml per kg. Important, very important, you give it very slowly. If you give the nurses very clear instructions. If you give it as a rapid bolus, it can lead to arrhythmias. Cardioprotective effect is immediate. Then you can nebulize to shift the potassium into the cell for about 5 minutes. You can do in 2-hourly intervals. Then you can, if there's acidosis, you can give bicarbonate. That again shifts the potassium into the cells. You can start an insulin glucose infusion. So these are the measures you can take. You can start calcium resonium, which removes the potassium from the body, but that takes a long time, at least more than 24 hours to start acting. So these are the three methods that will come to you in will help you to reduce the hyperkalemia. So treatment of hyponatremia. Hyponatremia in acute kidney injury is usually due to hyponatremic dehydration or due to fluid overload. So no replacement can be, sodium replacement can be fatal due to fluid overload and worsening CNS signs. In the absence of any neurological or ongoing sodium losses, fluid restriction is usually sufficient to manage hyponatremia. So if the blood sodium level is below 120, there is a risk of CNS damage. You will raise it to a safe level of 125 by using this formula, and further correction can be done with fluid restriction. Metabolic acidosis is usually caused by impaired acid excretion and increased production by underlying conditions. Rapid correction can lead to hypokalemic tetany or seizures. So check the ionized calcium level and correct before starting treatment. So when do you start treating metabolic acidosis is if there is hyperkalemia or if there is severe acidosis, like in pH below 7.2. You correct with bicarbonate if the serum bicarbonate level is less than 18, because then only that is where the maximum respiratory compensation takes place. If the patient is well, you can give it orally. If it is if unwell, you can give it IV. This is how you calculate the dose over 1 hour. So hypertension in acute kidney injury can be usually caused by fluid overload, can be due to intensive vasoconstriction due to hypovolemia and alteration of vascular tone. So choice of antihypertensives depends on the severity, cause, and your availability. Commonly used oral hypertensives are nifedipine, prazosin, furosemide. Don't use ACE inhibitors such as captopril, enalapril, or ARBs like losartan, because as I explained at the beginning, it can affect the renal blood flow and increase the creatinine and potassium further. So usually we use calcium channel blockers. If the patient is furosemide responsive, you can give furosemide. So what are the other aspects of management? Hypocalcemia, if the child is symptomatic, you give it give IV calcium gluconate, again very slowly. If there is hyperphosphatemia, you restrict the dietary phosphate intake and start oral phosphate binders such as oral calcium carbonate. Anemia might lead blood transfusion, or you can give Imetronix, or sometimes they need erythropoietin if the acute renal failure persists for long. Extremely important to think about nutrition. You have to give adequate calories to prevent catabolism and keep the urea and potassium at low level, because catabolism raises the potassium and urea. So extremely important, pay attention to what the child eats and give him adequate calories. We don't usually restrict dietary proteins unless the blood urea level is above 20 millimoles per liter. Drug dosing according to GFR is extremely important. We don't want to cause further injury by giving nephrotoxic medication. So especially when you're prescribing antibiotics, you calculate the GFR according to the Schwartz formula and follow the instructions in the BNF when calculating the dose. Then the next option is for starting renal replacement therapy. So when do you start renal replacement therapy? So if there is refractory hyperkalemia, severe fluid overloaded with pulmonary edema, which is resistant to diuretics, usually urea more than 40, which is usually symptomatic, patient can develop uremic symptom, or even if the urea is less than 40 with uremic symptoms, you have to consider starting renal replacement therapy. Then severe hypo or hyponatremia and acidosis, multi-organ failure. If you anticipate prolonged oliguria, such as in a case of hemorrhagic uremic syndrome, so that you can provide space for adequate dietary intake by increasing the fluid intake, These are the usual indications to start renal replacement therapy. What are the methods available? The peritoneal dialysis, which you don't need ICU care, which need very minimal equipment and expertise, can be done in a ward and very safe, can be done in a child with hemodynamic instability. And then hemodialysis, which is done over a short period of maximum 1 to 4 hours, like both CRRT and hemodialysis need insertion of central lines. So hemodialysis you are unable to do in a child with cardiovascular instability. At the moment, pediatric hemodialysis is only available at LRH and at Peradeniya Teaching Hospital. Adult centers can dialyze bigger children, but not small children. Then CRRT is a continuous removal of fluid over 24 hours, which can be attempted on a hemodynamically unstable patient with also a reduction in solutes. So recovery phase is also important. The child might develop polyuria, so you need to monitor them very frequently, hourly vital signs and hourly urine output. And for the first 24 hours, you replace milliliter to milliliter of fluid that is lost. In a well child, you can give it orally. In an unwell child, you can give it IV. So multiple replacement of urine output and insensible loss during the first 24 hours. If the blood urea and creatinine continue to improve and the urine output continue to improve, you can give a fixed volume after 24 hours. For example, you can give about 2/3 of the previous day's output, and the following day you can give half the previous day's output. If that equals to the maintenance, you can give maintenance. Like that, we slowly change our fluid management. Follow-up, extremely important. Children need long-term follow-up, unless they are AKI was caused by pre-renal injury, as you know, there won't be any structural problems. Why they need follow-up is in order to detect development of proteinuria, hypertension, and chronic kidney disease. How you monitor is check monthly. You need to check blood pressure and UFR on early morning sample for about a year. And then if there is, if no such development, you can monitor them annually. And creatinine, if there is, monitor the creatinine if there is any development of hypertension or proteinuria, in which case you will have to refer to a nephrologist. So I want to talk about avoidance of nephrotoxic injury, especially when you are prescribing antibiotics. Aminoglycosides notorious. The least nephrotoxic aminoglycoside is amikacin, which can be given daily, and vancomycin and cephalosporins. They are also can cause nephrotoxic. Try to use alternative antibiotics, and when available, we can monitor levels. In the best, they monitor the aminoglycoside and vancomycin levels. You need to adjust the dose according to the GFR. And sometimes we might have to think of using topical preparation. So antibiotics are not the only drugs. There are various other medications which are nephrotoxic, especially IV contrast. Especially when you order contrast-induced investigation, you have to be very careful. You have to avoid using in high-risk patients like volume-depleted patients, children having previous heart disease, previous renal disease, those who are on other medical nephrotoxic medications. So you need to discuss with the radiologist and ask whether it's possible to use half the dose. So you have to prehydrate and before and after the procedure in any risky patient. It has to be IV hydration, not oral. Then you monitor the creatinine before the investigation, 6 hours after, 12 hourly, 24 at 48 hours, because IV contrast nephropathy usually will happen during the first 48 hours after the administration of the IV contrast. And if it does happen, it usually causes a non-oliguric urinary failure. Sometimes we consider bicarbonate treatment with sodium bicarbonate, mannitol, or N-acetylcysteine. So ACE inhibitors, especially babies with congenital heart disease or heart failure, they are on ACE inhibitors and diuretics. Be careful when you, if you come across such a patient who comes to you with hypovolemia, like in diarrhea, vomiting, might have to stop them transiently. So what are the renoprotective measures that you have to follow in managing all your patients who get admitted to your ward, under your care? So you have to identify the children at risk of developing AKI. Ensure that they have adequate renal blood flow with normal blood pressure, good femoral pulse. Avoid nephrotoxic medications. Adjust the dose according to GFR. And relieve any obstruction to urine flow if you suspect there is any obstruction by way of catheterization. To summarize what I said, AKI increases mortality. Therefore, prevention of developing AKI is extremely important. Identify the patient as at risk of developing acute kidney injury and closely monitor the urine output and creatinine in such patients. Early and adequate fluid management to maintain renal blood flow can prevent the development of acute kidney injury, and always ensure renoprotective measures in all the children admitted to hospital who are under your care. Thank you.
Everyone, good morning. So I'll be talking about how to approach an acutely ill pediatric patient, right? So it's almost like the structured approach in adults, but there are certain instances where you have to be a bit careful in children because they are very small and they can deteriorate very easily, right? So I'll go through it as a lecture, and so at the end of it, if you have any questions, you are welcome to ask, or you can put up in the chat box, right? I'll be more than happy to answer. Right? Okay, so let's go to the next slide. Okay, so now this is what we are all worried about: a cardiac arrest, right? So a cardiac arrest is a pre-terminal condition. That means the heart stops beating, right? So unless you do something about this immediately, right, the patient is going to die, right? So at all costs, we should avoid it. If not, if you detect it early, if we detect it on time, we need to act very fast, right? So to prevent a certain death, right? So the basic difference between cardiac arrest in a child and an adult is that in adults, the cardiac arrests are mainly due to primary cardiac issues, like say a massive myocardial infarction, or an arrhythmia, that is because like adults have old hearts, they are pathological, so they tend to have a primary cardiac issue. So they go into a cardiac arrest because of that. So when they go into cardiac arrest, so the basic rhythm that they will have is a ventricular fibrillation or a ventricular tachycardia, right? So these two will definitely need reversing of the rhythm. So apart from giving good quality cardiopulmonary resuscitation, you will need to use a defibrillator, right? So that's one of the main differences between a cardiac arrest in an adult and in a child, because in a child, generally the hearts are very healthy, unless of course it's a child with a congenital heart disease. Most of the times they go into cardiac arrest because of shock, that is circulatory failure, untreated shock, like say dengue hemorrhagic fever or diarrhea dehydration, or a respiratory failure like a pneumonia or asthma which is not treated, and they end up with a respiratory failure or a circulatory failure, which in turn will cause a cardiac arrest. So these rhythms are generally a pulseless electrical activity or asystole, where you don't need to actually shock them, right, with a defibrillator. So this is the basic difference, right? And so good quality CPR is important in both the types of arrest, but in an adult, you will need to think about a defibrillator. Whereas in children, of course, the rhythm, if it's a VF or a VT, you might need, but otherwise, most of the times, it's not, right? And then the other important point is, so if there's a child who's breathing very fast, grunting, right? You need to escalate your management because he's going towards a respiratory failure. So unless you treat that, he will invariably end up with a cardiac arrest, right? So that's the basic difference between cardiac arrest in a child and in an adult, right? So now these are some of the causes of respiratory failure and circulatory failure. I'm sure you know about all these causes, just go through it, right? So foreign body aspirations, asthma, then respiratory depression due to convulsions, then if it's a pneumonia, all these can cause a respiratory failure. If not treated appropriately, we'll end up with a cardiac arrest, right? And then, of course, circulatory failure causes like dengue shock, diarrhea dehydrations, bleeding, right? And cardiogenic shock, all these causes can lead to a shock. Unless treated well, they will end up with a cardiac arrest, right? Okay. So these are some of the examples. If you work in ED, emergency department, that would present you as acutely ill patients. Of course, there are so many. These are some of the ways that they could present. Like say, they could come with a sudden obstructed airway, say like with a crew or a foreign body, or say maybe a anaphylaxis, right? So something like that, or as impending respiratory arrest, like say a child is almost gasping, not breathing well, right? So very feeble effort, so impending respiratory arrest, or intractable seizures. Child is convulsing rapidly, right, for a long period. It's a status epilepticus, so that could be another presentation, right? And then of course, slow pulse with poor signs of life. That is all. If the heart rate is below 60, of course, I'm sure you would have been taught it's treated as a cardiac arrest, and you will need to start your cardiopulmonary resuscitation. So these are some of the presentations that could come to you if you are working in an emergency department, right? Okay. Right. So these are the basic differences, right, between adults and children, right? So children, their compensatory mechanisms are are very good initially, right? So it could be like a child who has, say, who is in shock, right? But when you check the blood pressure, it might be slightly high. You might wonder, okay, but other signs of shock are there, but blood pressure is sort of shooting up. That may be because there is a lot of catecholamines being secreted, and it's like a pre-terminal condition where the blood pressure, because of vasoconstriction, the blood pressure shoots up, or extreme tachycardia, right? So you might think, okay, the heart rate's good and the blood pressure is fine, but next moment it could be quite catastrophic, and his compensatory mechanisms could fail, right? And child would end up with a cardiac arrest, right? So that's quite misleading. So you have to, in children, the compensatory mechanisms may mask the actual severe illness. So you have to have a very high index of suspicion, right? And then the other thing is smaller physiological reserves. That is, say now if you take an adult and a small child, right? If an adult is in respiratory distress, he has better muscle mass, he has a big liver with a lot of glycogen, so he would, go on breathing like that for a longer time, right? Whereas if it's a small baby, muscles are small, right? And then the liver is small, glycogen storage is not adequate. So the physiological reserves are less. So he would end up with respiratory arrest sooner than the adult, right? And then children are, of course, difficult to assess. It might be a severely dyspneic child, but child is crying continuously, so he won't let you examine. So you will miss the respiratory distress. You might attribute to the crying, and you might think, okay, I can see this child later. But later on you might find child is in respiratory arrest. So it's quite difficult to assess them, right? And then of course the technical procedures are more difficult. Now, see, intubating a 1-month-old is much more difficult than intubating a 20-year-old adult, right? Because the mouth is small, airway anatomy is different, right? So with all that, your technical procedures are going to be difficult as well. And getting a cannula in also might be a nightmare in a very small baby. So because of all these things, babies or children, right, could deteriorate much more faster than adults. So you have to keep this in mind, because if you had worked in an adult ward for a very long time, so you might think, okay, this baby also might be all right with this sort of findings, but it might mislead you, right? Very soon you might find the child arrested. So you have to always bear in mind that children will deteriorate very rapidly. So always you have a very high index of suspicion. Is this a bad patient? Am I missing something? Always, try to look and treat whatever is appropriate, right? Okay. So this is the traditional medical model that we learned in medical schools. You take a good history, okay, fever for 3 days, examine the child, okay, there's a bit of a right hypochondriac tenderness, and blood pressure is fine, right? And then you think, okay, could it be a dengue fever or a dengue hemorrhagic fever? Then you do some blood tests and wait for it. Do a full blood count, and then okay, WBC is 3,000, platelets 120,000. Oh, could be a dengue fever or a dengue hemorrhagic. So should we admit and start monitoring them? So yes, you have enough time in your hands, right? So you can leisurely see this patient because the patient is stable. But in an emergency way, like in a ETU or emergency department, the situation is different. Child comes gasping, and then if you think, okay, take a small history, okay, cough for 3 days, fever 2 days, difficulty in breathing for a day, and when you start taking the history itself, the patient will get arrested, will die. So here, you can't apply this traditional medical model in an emergency setup, right? Or in a bad patient, right? Your history examination, they don't take priority there, right? So that's where the structured approach comes in, right? So because now it's a bad patient, you don't have time to take a big history, and you don't know what sort of a diagnosis you are dealing with, right? And you really don't know what the only thing you know is, okay, it's a very bad patient because it's been triaged and they are detected it's a bad patient is in your hands, right? Now you are stressed out, and you don't think rationally. So what should we do? Should we try to make a diagnosis and treat? No, you can't. So because that's why the structured approach is very important, because even though you are under stress, right, it could be recalled very easily, right, and easily learned, right? So regardless of the diagnosis, this approach will save this patient's life, right? So because diagnosis will take some time, right? But if you approach this patient systematically and apply this structured approach, okay, first I have to look after the airway, then look after breathing, then the circulation, right? Then you don't try to think, okay, should I get in a cannula first? Should I put some oxygen first? Or should I check the CBS first? So if you jumble up, with your thinking process, by the time you decide, okay, I'm going to give some oxygen, patient that die, right? So, and the diagnosis, if I may tell you, now if it's a patient with wheezing and difficulty in breathing, so it could be a bad asthma, could be could even be a cardiac asthma, right? In heart failure. But either way, if the SATs are low, important thing is you give some oxygen, right? Or if the distress is more, you need to start oxygen before you come to a diagnosis, right? Whether it's dengue shock or diarrhea, dehydration shock. Important thing is you get in a cannula and start your bolus, right? So that's where the structured approach comes in, right? You don't need to worry so much. It's a bad patient. Let me, have clarity in my mind. Let me get the airway first, then the breathing, then the circulation, and then if you have help, you can assign to each other, but go in that priority, right? You don't need to, get stressed out so much, right? So the structured approach, there is something called a blueprint, right? So blueprint is your basic plan. This is how we are going to approach this seriously ill patient. So for any patient, right, who is very bad, like say an unresponsive patient whom you found on, of course, a doctor's approach. That is, D means you should get the patient out of danger. R means, is the child responsive? So if the child is not responsive, then of course you are in serious trouble. Child could be in cardiac arrest. So S is shout for help. So that's your BLS, basic life support. Doctor's approach. So are we out of danger? Right? Is he responsive? Not. If not, quickly shout for help. Right? So this is what happens in the basic setup. But of course, in a hospital, when a patient is brought, this will be done at the triage desk. There will be a triaging officer, nursing officer, who will categorize patients according to the severity of their illness. Right? So when you triage them, there are 3 lanes: red, orange, and green. So red means you need to approach them very immediately, urgently, right? So we'll say a person who has come with difficulty in breathing, right? So can't talk, can't breathe. So there's a stridor, very bad patient. So quickly and get them into the ETU, right? So when you are getting, so that patient will not go to the OPD. So that also, if it's red, he will end up in the resuscitation bed. So quickly get this patient, triage him, and bring him. So we'll say, okay, this patient is having difficulty in breathing, right? And so looks like an asthma, but there's difficulty in it. So quickly get the patient. So how are I going to position him? That's the next thing. So difficulty in breathing, prop them up. Keep in the resuscitation area, prop them up, right? And then your initial stabilization. Okay, airway, is the airway patent? Breathing, no, he's breathing very fast. His sats are low. Start some oxygen. So like that, A, B, C, D, E, right? So give some oxygen, support his breathing. Maybe, right, he needs some support, right? Maybe he needs to be bagged. Maybe he needs a cannula and fluids. So you, after your initial stabilization, you start your after your initial assessment, you start your initial stabilization, right? So, okay, now you got it. So we'll say you have stabilized, you have done your initial stabilization, then you take a directed history. Okay, quick history. So it's a child who has come with a urticarial rash and difficulty in breathing, lot of wrong. I quickly ask them, has there been any previous allergies before? He said, yeah, yes. So it looks like an anaphylaxis. Has he had any anaphylaxis before? Yes. So then quickly start on your specific management, that is the anaphylaxis, right? Then after you give the anaphylaxis, okay, patient is all right, we'll say, right? And then, but still you have to be monitoring this patient, because again, he might need another shot of adrenaline, or maybe he needs an adrenaline infusion. So ongoing care should occur, right? So basically what you do is, patient comes to the hospital, triage, and then you identify it's a bad patient, quickly get them to the resuscitation area, right? Do the initial stabilization, that is your airway, breathing, circulation, disability, and exposure. Then after your initial stabilization, right, you take a quick history and quick examination, focused history. Don't waste a lot of time. Then start your comments and start your specific therapy. Say, as I said, adrenaline for anaphylaxis, IV antibiotics for a septic shock, then anti-snake venom for a snake bite, right? And then your ongoing care. Get your charts, start plotting those values, and start reassessing the patient, right? And then disposal. So that is the other. Okay. So this is your structured approach, the blueprint. Right. So the doctor's approach I have already discussed. So danger, outer danger, scene safety, and then is the patient responsive? And if not, you send for help, right? So always remember about personal protection. So you all know during COVID period, yes, we had these PPs that we used to wear to protect ourselves. And even now, if it's like a very, say like we are dealing with a meningococcemia, if you have to intubate or something, you have to have proper protection, protective gear. and then say, so, and the other thing is poisoning. Say we say a patient with OP poisoning, he is like drowned in OP, so you don't get contaminated, you don't become a second victim. So wear your gloves, your apron and everything, right? So you have to take care of yourself. Now, this is what I talked about earlier, triaging. So imminent life-threatening conditions, they are categorized as red. Then the potentially life-threatening ones are categorized as orange. Less urgent ones are green. So this is a traffic light system, right? So red ones, they end up in the resuscitation bed immediately, right? So we said children with, so we'll just take one example. So we say it's an asthmatic, right? Like audible or a silent chest, a drowsy child, like with a lot of effort and almost going to like, almost there are signs of exhaustion, he'll end up in the red category. Now, the same asthmatic will end up in the orange category if he's a bit dyspneic, but no signs of exhaustion, no major distress, slightly dyspnea, mild dyspnea, right? There's history of asthma. Will end up in the orange category where you see them early, but you don't need to be as urgent as the previous patient. Then, of course, the green ones are the ones, okay, past history of asthma, he has a bit of cough, not distinct, not tachypneic, such are fine. You don't need to worry about them so much, but you'll see them in due time, okay? So that's how you categorize them. So this is about triage. So in the appropriate area at an appropriate time. So that's where how you triage. So these are some of the triage red flags. So if you are one of the doctors or the nurses who are there in the triaging desk, if these things are there, you have to get them in the category and should attend to this patient immediately. So if it's a lethargic child, decreased activity, difficulty arousing them. So this is very important, especially for children who are coming in the night. So I had a patient once when I worked in the periphery. So when I went for the morning ward round, I saw this child who had come with vomiting and fever. So when I saw the child, the GCS was around 3 or 4, but then it had not been detected. The child had come around 3 a.m. in the morning, and the medical officer who had been there had thought it's like late in the night, so he's sleeping. But actually, it's not that he's sleepy. It's just that his GCS is low because of the raised ICP. So it turned out to be a meningoencephalitis. So you have to be very careful. Even if they come in the night, always wake them up, see what their GCS is like, at least AVPO, right? See whether he's alert, he's only responsive to verbal stimuli, whether he's only responsive to pain, right? Or whether he's unresponsive, right? AVPO or GCS is very important. So that's how this sort of patients should end up in the red category. And then, of course, very increased respiratory effort, grunting, right? So this is an ominous sign. Grunting is a very bad sign. Right? That is grunting. So if there's a child who is grunting, I had seen sometimes some people just write grunting and move on to the next patient. That's not going to help. But if it's a child with grunting, if you don't escalate your treatment to something like a high flow or a CPAP, right? Child is invariably going to get arrested, going to go into respiratory arrest, right? So a child with grunting, don't just put for nebulization or put some oxygen and wait for your consultant. Grunting child is a very dangerous child who is going to get arrested very soon. So you have to give them a good PEEP, that is a positive end expiratory pressure. For that, you need a high flow machine or a CPAP, right? So you need, otherwise, if you don't have those, you need to shift this patient out to a center where these facilities are there. So please remember that grunting is something like this, right? So it's an expiratory noise. So that's a very ominous sign where people don't give due respect to this will suffer, right? So please be careful with them. And then if the child is very pale or mottled, could be in severe profound shock. Again, send them to the red category to the resuscitation bed. And then if there is decreased oral intake or less than 4 wet nappies a day or reduced urine output, you have to be very careful about these patients as well. Then, of course, in the current context, if the fever is high and they are flushed, then think about dengue. And then if there is significant limb pain in a febrile child, it could again be a dengue or a influenza, right? Right. So now we are triaged and we know where the patient goes. Now we'll say it's a bad patient, red category. So you have to quickly bring them to the to the ETU, where you get them to either bed 1 or 2, the resuscitation beds, the red area. And so if it's a patient with asthma, pneumonia, or severe stridor with respiratory distress, right, prop them up and keep them on the bed. But mind you, this severe stridor, you have to be careful. If it's epiglottitis or something, you try to manhandle the patient, like try to put them, on the bed and all that, child might, get a laryngospasm and might go into respiratory arrest. So please be careful. If it's a child with stridor, let him maintain his own happy position, right? Because if it's a stridor, he will maintain a tripod position, right? So don't mess too much with the patient with a stridor, right? And then, of course, if it's a child who's fitting, right? Then you need to put them to left lateral position for the secretions to come out. And then if it's a patient in shock, say like anaphylaxis or something, you should elevate the legs so that the preferential blood flow will be towards the brain. The gravity helps the blood to be somewhere around the brain, right? And then if it's a raised ICP again, patient should be in a propped up position so that the venous return to the heart will be enhanced and venous engorgement will be less, thus reducing the raised ICP. Okay, so these are some of the examples for the positions. So even though we say, okay, airway, breathing, circulation, disability, exposure, this should be the priority order. But then if you have a good team, one can look after the airway, the other one can assess the breathing, the other person can look after the circulation, right? So if you have a lot of hands, this all should be parallel processes. So everything happens at the same time. So within a short period of time, you have assessed and done your initial stabilization. So one is already bagging the patient here, the other one has detected shock and is giving a bolus, right? And so that way, you're going to save very, very precious time for this patient to survive, right? Okay. So this is the pediatric assessment triangle, right? Again, all the stuff that we talked about earlier. So one end is airway and workup breathing. The other thing is other side is circulation and organ perfusion. Then of course, brain perfusion, right? So A, B, C, D, right? So yeah, so anyway, we'll go into detail afterwards. I'm sure you would have had individual lectures on this about airway and workup breathing, right? So airway, you look for any obvious foreign body secretions, any gurgling noises, right? So if you want to open the airway, you might use a double-handed jaw thrust, right? Or you might use a tilt and chin lift, right? So do all those maneuvers, or if there are secretions, suck them out, clear the airway. Then you assess for workup breathing. So it could be either effort or efficacy, right? So effort means you are assessing the respiratory rate, the distress, like how bad are the recessions, right? So from that, you can get an idea about the workup breathing. And then, of course, efficacy is breathing is something like you look for chest expansion, right? And then look for saturation. So how efficacious our breathing is. So these things will give you an idea about the airway and breathing status of this patient. So if the airway is not good, even though with the jaw thrust and all, you can't maintain the airway, or there is something obstructing the airway, you might need to put in a oropharyngeal airway, or you might even need to intubate the patient, right? Then breathing is not good, almost a gasping type of breathing, effort is not good, right? You might need to bag the patient. So get a proper bag and a mask and start bagging. So if the respiratory arrest is like prolonged, then of course you might need to intubate and start bagging the patient. Then for circulation, right? So you look for the pulse, volume, the blood pressure, the heart rate, look for tachycardia, right? Cold peripheries, if these things are there and the blood pressure is low, it's a shock. Then of course, get in IV access, quickly give a fluid bolus, right? So then, for the disability, you assess the conscious level, you use your AVPU or your GCS. So if that is low, of course, it's a patient who is having a CNS failure. So if the GCS is below 8 again, you might need to intubate to protect the airway. And of course, you might use 3% saline or mannitol to reduce the raised ICP. And then other two things are the pupils and the posture, again, which will tell you if there's a CNS failure or not. So if these are there, then of course, it's a very critically ill patient that you're dealing with, right? Right. So what we need to see is there a potential respiratory failure? Is there a potential circulatory failure? Or is there a potential neurological failure? So if these are there, right? So if one if one of these failures are there, then if you don't attend to it, it's going to kill the patient. So before that, you have to attend, right? So airway assessment I had already discussed about, right? So if it's a talking or crying child, then of course the airway is assumed to be normal, right? So abnormal airway sounds I discussed earlier about the grunt. Then there are two other abnormal sounds, inaudible wheeze, where you can hear it from a distance rather than even without a stethoscope, or a stridor. Stridors are mainly inspiratory, right? Like that, right? So with the stridor, again, you have to be careful. It's upper airway obstruction. If it gets obstructed, it's going to be a nightmare. Intubating them will be difficult. So you might need to go for a front of neck access, right? Like a plecothyroidotomy or something. So you have to be very careful. So always respect be very careful with patients with a stridor or a grunt, because if you don't attend to them immediately, you're going to have, bad repercussions, right? Okay. So then, as I said earlier, secretions drooling unconscious child, airway might be not protected. So GC is below 8, you might end up intubating them, right? So then the airway opening maneuvers I discussed earlier, but then I'm sure you would have had a different, like a separate lecture on this, right? So in a bigger child, we try to maintain the sniffing position. So under 1 year, we try to maintain the neutral position to keep the airway patent, right? And then you might have various adjuncts like oral airways, right? And endotracheal tube. And then, so this also I discussed earlier about effort and efficacy. So effort is the respiratory rate, right? Rhythm, accessory muscles used, resistance, flaring of LNSA, right? And then child's position, especially if it's like a tripod position, right? It will be suggestive of glottitis. Then signs of respiratory failure, that is about efficacy. The child is drowsy, it could be because there is hypoxia, brain hypoxia, because the lungs are not functioning properly. And then of course you look at chest expansion, air entry, pulse oximetry will give you an idea about how efficacious the breathing is, right? And so to remember, cyanosis is a pre-terminal condition. So don't wait for it. So when there is cyanosis, oxygen saturation is generally below 85%. So you should never wait for it. So generally below 92, if the sacs are below 92, the oxygen, the PO2, that is the partial pressure of oxygen in blood, will drop drastically. So generally in the wards, when it's below 94, we tend to start them on oxygen so that they maintain the oxygen level in a safer region, right? So below 94, better to start them on oxygen. And then these are also some of the concerns. These are seen, right? It could be that patient is going to a respiratory arrest, right? If the respiratory rate is too low for the age, right? So that means it's almost impending respiratory failure. And high respiratory rate, of course, if you don't, take proper measures like a high flow, starting them on high flow or CPAP, or maybe ventilating them, they will also end up in respiratory failure. And then peripheral cyanosis again shows that, your breathing is not very efficacious. That's why it's cyanose, right? Then as I mentioned earlier, if there's brain hypoxia because of respiratory issues, patient could be agitated and confused, right? And if you can't hear, if the lungs are silent, when you auscultate, you can't hear anything. That again is indicator of severe bronchospasm, right? So it's a silent chest. You need to act immediately, right? And then you are doing everything possible. You have started your high flow. You are giving fluids, you have given antibiotics, but still it's going down, his effect is getting worse, lot of resistance. You will need to intubate this patient, connect to a ventilator. Otherwise, sooner or later, he's going to end up in a respiratory arrest. So it's better to intubate them, before they get arrested, so that the outcome is better. So in certain patients, if it's a weak patient or who is exhausted, respiratory distress not be seen. So same way, if it's a child with a neuromuscular disorder or like spinal muscular atrophy or acute flaccid paralysis like Guillain-Barré, you might not see the distress even though they are hypoxic, right? So other thing is, if there's raised ICP, then again, the respiratory center is compressed and even the respiratory effort might not be visualized, right? So these are some of the normal. So the important thing is, you can't remember these. So if you are dealing with children, always have these charts. the normal heart rates, the normal respiratory rates, the normal blood pressure values for children if you are dealing with children, because you can't remember, right? You have to always see them and compare with them, right? So these are some of the airway equipment that we use, the tubes, the bag and mask, right? And the laryngoscopes, right? I have discussed about the positions that we use, right? And then non-invasive ventilation, right? BiPAP or CPAP or high flow, right? And then bag and mask ventilation as well, right? So parallel processes I have discussed already, right? And right, we have discussed about shock, right? And this is how you look for capillary fill time. So you press and count, keep pressed for about 5 seconds. So 1 in 1,000, 2 in 1,000, 3 in 1,000, 4 in 1,000, 5 in 1,000. Let go, 1 in 1,000, 2 in 1,000. So the capillary fill time should be less than 2 seconds. If not, it could be that the child is in shock, right? So these are all features that you look for shock. The capillary fill time, the pulse volume, the tachycardia, right? And then the blood pressure, right? And look for a line of coldness. So these are the normal heart rates for age. And so if the heart rate outside normal range, so tachycardia is a consistent sign of shock, and it's a good indicator of serious. So when you give boluses, when the shock is getting treated, the heart rate will slowly calm down. But if there is clinical deterioration and the heart rate is falling, it could be that he's going into cardiac arrest. So if the heart rate is dropping and the patient has good clinical improvement, that's all well and good. But if the patient's clinical deterioration is also there and your heart rate's also dropping, then please be careful. It might be that patient is going into a cardiac arrest, right? So remember, this is very valuable. This is a very this thing just to know that with hypotension, right? Hypotension is a pre-terminal sign. So hypotension means the blood pressure is below the fifth centile for the systolic blood pressure, right? So if this persists, there will be shock. Shock means the organ perfusion is affected and end organ damage is there. So the first thing drop will be the blood pressure, the urine output will reduce, right? And then child will be drowsy and then will cause cardiac arrest, right? So hypotension, you have to always treat very quickly, right? So over 1 year to 10 years, 1 to 10 years, there's a formula, 70 plus age into 2. So we'll say the child is 5 years old, right? So 5 into 2 is 10, 70 plus 10 is 80. So for a 5-year-old, the lowest blood pressure he should have is 80. So generally, after 10 years, their blood pressure is 90/60, right? Okay. So 1 to 10 years, this is the formula to use to get the lowest physiological, lowest blood pressure that is normal for them, right? Okay. So again, IV access. If you can't get IV access in a patient with shock, we'll go for intraosseous access, right? So again, with the first cannula, you take a sugar, full blood count, a venous blood gas, very informative, right? To know about the electrolytes and all those things, and the lactate and the pH and all, right? Blood culture, electrolytes, grouping, and RH in case we need to transfuse the patient, right? So IV fluid for boluses is always normal saline, and the usual volume is 20 milliliters per kilogram. And there are few exceptions. One is compensated Ding shock, where you will give 10 ml per kg. Then neonatal resuscitation, where again you will give 10 ml per kg. Then DKA, again, where you will give 10 ml per kg boluses. And then again trauma, 10 ml per kg boluses will use, right? So these are the instances where 10 per kg boluses are used. Or in all other instances is 20. So we have to reassess after each and every bolus, right? So these are some of the features of cardiogenic shock: a gallop rhythm, enlarged liver, tachycardia. Tachycardia is out of proportion, unlike in other types of shock, right? And then absent femoral pulses indicates critical aortic stenosis in a newborn, right? So always remember to look for femorals. So disability, I have discussed earlier, right? So that about the conscious state, right? So ABPU or GCS, right? So, but initially child could even be irritable or agitated, right? And the most important thing here is DEFG. Don't ever forget glucose. A, B, C, D is for disability, but we sometimes use a D, E, F, G is don't ever forget glucose because this could cause drowsiness and so many other issues. So always check for the sugar, right, in a seriously child. So disability assessment is conscious level, posture, and pupillary signs. So disability assessment, either you can use the AVPU score or, so generally if it's P or U, you have to be very careful. The child only responds to pain, that means, or pain means it's less than 8. So you need to intubate this patient. Unresponsive means something like less than 4 GCs, right? So this Glasgow Coma scale, I'm sure you can look up. And if it's below 8, of course, you need to protect the airway by intubating. And this is for below 4-year-olds. That's the separate chart, right? So this is posturing in the child who's seriously ill. Decorticate and decerebrate posturing, again indicative of raised ICP. So if pupils are sluggishly reactive or unequal, right, or non-reacting, indicative of raised ICP again. So again, central neurological failure, right? So exposure, so expose and look for any rashes, snake bite marks, right? Features of anaphylaxis. So this is meningococcemia, you have rashes, anaphylaxis, angioedema, lipedema, and particular rashes, right? So during your primary survey, what you're going to do is to see if there's a potential respiratory failure or a potential circulatory failure or a potential central neurological failure. So then, depending on the type of failure you have, you need to act quickly to prevent a cardiac arrest, right? So during the primary survey, if a patient is deteriorating, so imagine you are doing your primary survey and then the patient is deteriorating, stop. Then again go back to A, B, C, D and pick up the abnormality. So probably you earlier the airway was fine, and then when you were assessing, sats were dropping, and you were assessing the circulation, but sats are dropping, right? And the pulse volume also becomes a bit unpalpable. Then again quickly when you assess the airway, there's a lot of secretions obstructing the airway. So when you quickly suck out the secretions and reapply oxygen, okay, sats pick up, right? So you have to always stop and go back. Right? Treat the abnormality and then come back to where you were, right? So it's very important to do a simultaneous assessment and treatment, right? So monitor the patient by multi-para monitor wherever facilities are provided. So this is just to take a directed history, look for ample allergies, medications, past medical history, right? And then this is just the pain scoring, right? And then specific treatment I have already discussed earlier, right? What sort of, and then ongoing care is, right, you reassess, right, and then stabilize the patient, then either admit to ICU or HDU in a general ward. So transferring and handing over are very important, right? So when you hand over, use the IS bar system where you explain, identify yourself, I'm medical SHO or pediatric SHO, situation in child with anaphylaxis background, is he has past history of food allergies and anaphylaxis as well. So today, assessment is today, he came, his blood pressure was 70/40 in shock, and there were urticarial rashes, and we had given 2 doses of adrenaline. So at the moment, his blood pressure is all right. So our recommendations would be to monitor him closely. If there are other episodes of anaphylaxis, probably will need adrenaline infusion. So that's how you hand over to the other person on the other side. So if it's surgical trauma patient, so you have to tell about the mechanism of injury, missed, right? Injuries observed, and what are the vital signs and treatment offered, right? So in summary, don't make diagnosis when you are dealing with bad patients, right? So only go according to blueprint. So triage them, right? And position them properly. And then your primary survey is airway, breathing, circulation, and neurology, like disability, right? A, B, C, D, and then do the exposure, right? So do the primary resuscitation, needs a bolus, needs oxygen, do all that. Keep reassessing until they are stable, right? And then after you have reassessed and stabilized them, come take a quick history, focus history and examination, come to a tentative diagnosis, right? And then secondary survey and stabilization. Then keep monitoring and hand over to the ICU or to a ward for ongoing care. Okay. So thank you very much, right? The summaries, of course, so you have to keep your assessment brief and focus, A, B, C, D, right? Resuscitate without delay. Don't take like too much resuscitation is the most important thing. And in emergency treatment is based on best guess diagnosis, right? So you can't be waiting for your investigation. So your clinical diagnosis is the most important. So keep reassessing them, right? To make sure that they are stable, and your investigations should not delay your treatment. And definitive diagnosis and management is once the patient is stabilized, right? Okay. So I hope it was clear to you, and thank you very much. And if there are any questions, I would like to answer. Otherwise, we can move on.
Good afternoon, everyone. It's good to see you here as part of the pre-intern teaching. This next lecture will be on approach to a child with trauma. My name is Prasanna. I'm one of the consultant emergency physicians attached to the Lady Ritchie Hospital Accident Emergency Services. And we'll have a look on how to manage a severely ill patient or severely injured child. Now, coming to trauma, there's quite a lot of things to talk about. We can't really complete everything in half an hour's time, but the objective is mostly focused on a structured approach, which is time sensitive, because you as interns will be seeing the patients first before you register your consultant. So there are a few things that you can do which will prolong your patient's outcome. So as part of this lecture, we're focusing on the difference between management of a pediatric trauma compared to adults. Then the most important one is the structured approach to a seriously injured child. Thirdly, a few management of common pediatric trauma scenarios. Okay. So there are a few things you should appreciate when it comes to pediatric trauma. So you have a physical difference, psychological difference, and physiological differences. So anatomy and physiology, if you recall your medical school days, you realize that they have large mobile head and they have weak neck. The ribs are very soft and pliant. So even though they don't have any obvious rib fractures, the internal structures can be damaged. And if you can recall the pediatric abdomen, they are more exposed to trauma than the adults. And when you think about the lungs, they have reduced functional vesicular capacity and higher O2 consumption, which will give you, or which you had to consider when you're thinking of intubating these patients or thinking about ARB issues in these patients. The second most important thing is the psychological issue. Now remember, these are children. They can be from any age, from probably newborn to 13, 14 years. So you realize that they have fears of these certain procedures. They'll be afraid of the needles. There can be anxiety because of parent separation, or they'll be anxious just to be in the middle of strangers. So you had to realize the difference between that and, as you know, from a real pathology as well. Also, with the age, you may find it difficult to actually find what problem they're having as well. The most common scenarios of real, most severe injuries are usually due to motor vehicle accidents, falls, and also by drowning as well. We do get burns at times. And also always remember to exclude non-accidental injury in your children. Okay. Now, since we are thinking of intern level, now what's important for you is good communication as well as good primary assessment. So you can use the ISPA format, which you'll be learning in your practice. There's also what we call the administer, which you can see here, which is more specifically suited to trauma settings as well. Okay. Right. So how do we manage a seriously injured child? So it's a structured approach. We try to make things simple. We don't tend to think too much. So remember, the children are very severely injured, severely ill, so you don't have much time to do each and everything. So you need to have a good, rapid, systematic assessment to find life-threatening injuries, treat it before you move on, right? So part of it is doing a primary survey, doing a resuscitation side by side with that, and once patient's a bit stable with your primary survey, you'll do a secondary survey, do the emergency treatment, and continuous stabilization as well as plan for transfer of this patient to the operation theatre, ward, or the ICU, or even to a tertiary center. So in an ideal setup, especially in the tertiary hospitals, there will be a trauma call activated before the patient comes to you. And if you're on the receiving end of it, inform your seniors so they'll be there in the resus room, and also inform the radiology department that you may need any portable imaging as well ultrasound, also inform the blood bank in case you need massive transfusion. So the primary survey is the most important one for you guys, because you'll be seeing the patient first. So compared to the usual ABCD with the medical management, you see there's an extra C in the beginning. So that is for catastrophic bleeding. So you look for any catastrophic external hemorrhage. You try to stop them. Then you go with airway. So you see it is paired with something else. Okay. So you look at airway first with C-spine control. Then you move to breathing with ventilatory support. Then you move to circulation with hemorrhagic control. Then disability with prevention of secondary insult. And exposure with temperature control and reassessment. So remember, the primary survey is a rapid structured approach, and you go in a systematic approach from most serious problems that will kill the patients on the order of priority. You need to find them, and you need to treat the problems as you find them. Okay. So the first one in trauma is catastrophic bleeding. So what is catastrophic bleeding? It means obvious exsanguinity in hemorrhages, that is like spurting arterial bleeding, or any large amount of bleeding that's going to get all or nearly most of the blood volume of the patient out of the patient. So the best and easy way, if you think of it in a systematic way, first thing you can do is you try to apply direct pressure on top of the bleeding point. So even an arterial bleeding, you apply 10 minutes of good pressure, it can be settled. And let's say if you're not getting the desired effect with pressure alone, you can get some gauze and you can try packing the wound to see if that's enough. So the packing wound is also like applying pressure. And even if that seems to be difficult, then you need to think of applying a tourniquet in these patients. And as interns, I would expect you guys to get down your seniors before you come to that decision. But it is still something that you can do if you can't find people. But always remember, all the emergency management start with simple approach first. So most of the time, nearly 90% of the time, simple direct pressure should be enough to control a catastrophic external hemorrhage. And when you get these patients, remember, now there's going to be blood, there's going to be vomiters, there's going to be all sort of fluids around. So make sure you get your personal protective equipments in. Make sure the scene is safe, and always look for an active bleeding. The most look at the limbs, especially the femoral artery, where because people don't tend to pull down the torsion, but that's where your patient will be bleeding and dying. And if you see any catastrophic bleeding, please apply direct pressure, keep it for 10 minutes straight, and call for more help. Right. And if you think the artery is in a place where you can't effectively apply pressure, like I told you, try to get a packing done. And if packing is going to be difficult, try to get a tourniquet in. Right. And once you control catastrophic bleeding, you'll come to airway and C-spine. Right. So the thing about cervical spine in children is the children will be very uncooperative when they're in a new environment, when they see these new people sitting around, talking around them. So they may be uncooperative. They may have pain, they may have fear, and sometimes they can have hypoxia or hypovolemia, which is causing that act a bit different. So if you think patients bit not stable, you have to think of airway and that's the cervical spine. So we'll talk about cervical spine on the next slide, but we're going to delete that. Right, and after catastrophic bleeding, you look for any airway issues and C-spine issues. So how do you look for airway issues? You talk to the patient and you see how they can verbalize themselves. If they can talk, they can maintain the airway. If they can't, if they have any noises like gurgling noises, that means they got secretions in them. If they got stridor, there's upper airway obstruction or the tongue falling back. Right. So the usual management is you go for triple maneuvers, but in trauma, remember, you had to manage the cervical spine. So the first thing you need to do is go in and apply manual inner stabilization as shown here. Put both your hands with the forearms firm on the bed and make sure you are holding both the torso and the head, so there's no movement by the patient. Avoid putting hard collars because number one, the children may find it uncomfortable and they would try to start squirming, and also hard collars are not proven to have much benefit in acute management. You may end up having, so patients, if they're squirming, they can always turn their necks in relation to the head, so into the relation to the body, and sometimes they can have pressure injuries as well. If you got them, or if you can calm down the patient, you can put a soft collar over the sandbags. And if you're hearing noises, do not try to do the head tilt and chin lift. That's contraindicated in trauma. But just open the airway and try to remove any foreign objects or anything under direct vision. Please do not try to put your fingers into finger sweeps. You can use an oral airway as a simple adjunct, and if there's no basal skull fracture, you can consider nasopharyngeal tubes, but if you are in doubt, just use oral airway only. And if you think this patient is intubation or surgical airway, as in if you are really finding it difficult to manage the airway, get down your seniors to prepare for an intubation or surgical airway. Okay. And this slide shows the modified jaw thrust. So you see the patient's, so this is an adult patient, is kept in a sniffing position, and you can see the fingers are kept on the back of the mandible, angle of mandible, not over here, and they always keep the pressure over the bone, not over the soft tissue, and they just push the jaw up. That's how they manage the jaw thrust. And once the airway is being managed, you can move on to the breathing. So you look, listen and feel. So look for the respiratory rate. That's very important in children. Look for the chest expansion. Feel the trachea, see if there's any deviation. Do the percussion to see if there's dullness or hyperresonance. Listen for the air entry and check the saturation as well. You can also apply high flow oxygen. So generally try to use non-rebreathable mask airways. And you also, in your clinical examination, you try to rule out pneumothorax or hemothorax. So, I mean, you know from your clinicals how to identify tension pneumothorax. So once you find a pneumothorax, so remember in primary survey, when you find a trouble, you need to treat it before you go on. So if there's a tension pneumothorax, obvious tension, then you need to do a needle thoracentesis first to relieve the pressure. So you get a wide bone needle, get your ankle fluid, mark down the second intercostal space, and insert the needle straight down into mid-clavicular line. You should get a gush of air coming down, and the patient should feel a bit improved. And you should always follow this up with a proper intercostal chest tube, intercostal tube insertion. And if it's a massive hemothorax, remember the problem is here because of hypovolemia. So you need to get 2 vibo cannulas, get the blood for FPC and grouping and DT, and then get a chest drain inserted on the safe triangle, that on the ipsilateral side, that is just above the above the 5th intercostal space between the anterior and the mid axillary lines. And especially in children, you can get lung contusion as well. So when you examine them, they usually sometimes have reduced chest expansion. Not always, but remember in children in trauma situation, it's a bit difficult to appreciate chest expansion eye entry, but usually they are expected to be reduced chest expansion, diminished eye entry, but they will have a normal percussion node and the trachea is usually midline. And this is common in children because, as I told you, the ribs are very flexible. You don't really need to do anything except give oxygen by NRBA so they can maintain saturation. And if you've got an open pneumothorax, your patient will be having hypoxia because they are not having good effective ventilation. What you need to do is apply this 3-way plaster, which should sort of apply as a 1-way valve. You may also need to consider treating the hypotension as well as start, the other management as well, or think of putting an IC tube, proper IC tube in as well. And then you got flail chest. So you can see the paradoxical breathing. So the treatment is give high flow oxygen through NRBA, give good analgesia so the patient can breathe, because the trouble is usually because the patient finds it very painful to breathe and they go into this hypoventilation. So give them enough analgesia so they will be encouraged to breathe well. Sometimes you may even need to consider non-invasive ventilation or intubation as well, but this is something for your seniors to step in and take the decision on. Right, so these are the common trauma, the chest traumas that you get in adults as well. But remember, in children, because of the compliant chest wall and the mobile mediastinum, they may occur with less obvious external signs of even without any refractures as well. And when they have these injuries, they tend to have other injuries like a head injury as well. Okay. Once you satisfactorily manage breathing, then you move on to circulation with hemorrhage control. So look for obvious bleeding points. So what we say is you look for one on the floor and 4 more. So your patient may not be bleeding at the hospital, but they would have bled so much of the blood in the accident site. So ask the paramedic or the bystander if there's ask them to quantify the amount of bleeding on the site, the accident site, injury site itself. And also the 4 other sites where you get concealed bleeding are your pleural cavities, where you get hemothorax. You get then you get your abdominal cavity, concealed bleeding. Then you get in pelvic injuries with pelvic bleeding, which can still contain significant amount of blood volume. And last, long bones, especially the femur fractures. Okay. In children, as we will discuss later, you need to rely on the pulse rate, the pulse volume, as well as capillary refilling. The blood pressure is a vital sign which changes in very late shock. So it may be even like in second, third degree shocks, the blood pressure may be still look normal, but the pulse rate and the CRFT will be increased. So when you do your circulation, you look for any significant internal or external hemorrhages, look for any concealed bleeding, do an abdominal examination, look for any liver tenderness or splenic tenderness which may cause any abdominal bleeding. Check for pelvic fractures. If there's any fractures, try to apply a pelvic binder. Also expose and see if there's any upper thigh bleeding as well. So how do you manage if there's an issue here? Oops. So try to get 2 wide-bore cannulas, and if you can't get 2 cannulas within the first 10 seconds, try to get an intraosseous line in. Some of you may have access to intraosseous gun, or try to get a large bore blood needle into the patient's tibia. It's a bit easier in children. Send blood for full blood count and grouping and DT. So when you start working in the hospital, you really need to look through the request form for packed red cells, which gives you all the instruction regarding request in these bloods. So if you need to request O negative blood, it should be signed by a senior. So in a resuscitation situation, you request O negative blood if the patient is very hypervolemic, and if you think you can wait about 20 minutes, patients not too hypervolemic, but you can wait about 10-20 minutes, then you can ask for a group specific blood. And if you can wait about 40 minutes time, they can get a cross-match blood. So it's still risk benefit. Let's say you are worried about hypertension and shock, severe hypertension shock, then you need to get them as fast as possible. But you do need to remember that blood products do have risk of having any reactions, and they can sometimes go to death as well. So depending on the urgency, you can request any one of these 3 bloods. And when you need to give fluids, we always say try to go with blood as much as possible. And practically when you ask for blood, there's always a delay to get it down from the blood bank, possibly about 10 minutes for your attendant to go and bring it down. So if you think patient needs more fluid till then to maintain the perfusing volume, you can start with 10 ml per kg crystalloids. You can only repeat it up to 20 ml per kg, but do not go more than that. Patient really needs to have his blood. And the newer suggestion is just go with 10 ml per kg blood in all your patients, right? Always, and also consider the tranexamic acid in shocked trauma patients. The dose is 15 milligram per kg. So how I remember is the same dose as how you prescribe paracetamol to your pediatric patients. And if you think your patient will be needing more than 3 units of blood, consider activating a massive transfusion protocol. Now this is something I hope you'll be having your seniors during this resuscitation, and then they will be guiding you or telling you to start a massive transfusion protocol. So you need to familiarize with your hospital to how to do it. So most of the time you need to call the hospital blood bank and tell them about the patient, tell them the patient's weight, and say that you're going to activate massive transfusion, and tell them where the patient is, and they will start sending the blood packs to you. And avoid too much crystalloids as much as you can. It's only to bridge the gap between you to get the blood. So just go to 10 ml per kg. You can repeat it once, but that's the maximum crystalloid you need to give. Always try to get blood as much as you can. And in circulation, the emphasis is always on source control. Now if it's an external bleeding, you can easily manage it, but remember, if it's an internal bleeding, if it's, let's say, long bone fractures, then you need to splint them. If it's pelvic fracture, you can apply pelvic binder. Intra-abdominal bleeding is a bit tricky. You need to get them to the operation theater. Thoracic bleeding, again, depends on how severe it is. Some of them may need theater, some of them can be managed in the resus room. And like I told you, if you think your patient needs more than 3 units of blood, please consider activating the massive transfusion protocol, because when we say we are giving blood, we only give packed red cells. We are not giving the clotting factors and platelets, so you need to consider giving them as well. And if you want to exclude abdominal bleeding, you need to have that feel of doing abdominal examination to see that. And you can also practice yourself in doing fast scans as well, or on e-fast where you look for any bleeding in the pleural space as well. When you start the massive transfusion, follow the protocols of hospitals. I mean, the protocols are usually the same, but the hospital may have different little changes, so be familiar with that. Inform the hematologist, and if they do a ROTEM or rotational thromboelastometry, they will ask you to send another blood in the blue tube. That's a clotting profile tube, so they can do a ROTEM test. And if you can still, if you suspect pelvic bleeding, put a pelvic binder as well. And once you finish your primary survey, think of catheters in the patient if it's appropriate, because especially in children where you can't rely on most of the vital signs like in the adults, the perfusion of the kidneys usually give an idea of the perfusion status of the patient. So now this is something that you're familiar with. You would have learned this in your final exams, but in children, remember, they will maintain their blood pressure until they are up to class 4. So the more telltale signs in children are worsening tachycardia as well as increasing capillary refilling time. So even if the blood pressures look good, but if there's prolonged capillary refilling time, you need to consider that this patient is actually hypovolemic. So after you satisfactorily manage circulation, you move on to disability. So the simplest way to do it is you do an AVPU approach. So you check if the patient's alert or response only to voice. Response to voice or response only to pain, or if the patient is unresponsive at all. And remember, if the patient is responding only to pain, that means he can't maintain. So his GCS is low, less than 8. He can maintain the airway. So you need to consider getting on your seniors with regards to intubating this patient. You can also do a proper GCS assessment. So it's the eye component and the motor component are the same as the adults, but the verbal response changes a bit. You can always, refer it up in your mobile phone or Google if you're getting the proper GCS done. 2 signs that you need to appreciate in children is this abnormal flexion and abdominal extension. So this happens when there's progressive worsening severe traumatic brain injury. So you give a pain response and they do this abnormal flexion, we call it decorticate, and abdominal extension decerebrate. So I mean, the way how you remember it is, imagine he's catching a ball, like caught the ball. So the posture like catching a ball is decorticate, caught the ball is decorticate, and the other one is decerebrate. So you can do so what we check for in disability is the conscious level, the posture of the patient, as well as the pupil signs. So you look if the patient has equal or unequal pupil and the response as well. Okay. Then you go to exposure. Now this is you check only for life-threatening injuries. You remove the clothes, try to remove all the clothes as possible, and see until if there's any injuries, any bleeding and rashes that will cause any issues immediately. Check all surfaces and orifices, extremity and cavities as much as you can. And remember, even though I'm telling you that you need to remove the clothes, remember that there can be heat loss. The patient can become hypothermic, and patient may not. Patient will be a bit embarrassed as well. So just be the simple things do help. Just talk to the patient, reassure them, or keep someone that they trust nearby, so they will help you with the assessment. So those are skills that you need to learn. I can tell you about it, but these are things that you need to learn by doing it on your patients. And always maintain their temperatures. If you're giving fluids, make sure that you give warm fluids and you use heaters, or you reduce the AC in the room. Right. So just to recap on the primary survey, so you do a systematic assessment, you look at things that cause issues, you look for them and you treat them as you find out. Okay, so C is remember catastrophic bleeding, Then you have airway issues, could be due to inhalation injury or direct trauma. Breathing, you can have tension or open pneumothorax, massive hemothorax or flail chest. C, you can have uncontrolled hemorrhage in chest, abdomen, pelvis, long bones, tamponade, and sometimes in burns. And also remember, in very small infants, newborns, you can actually have large amount of blood hidden in the scalp hematoma as well. And in disability, you look for any features of traumatic brain injury like raised ICP, expanded bleed spinal injury, and exposure. You look for any other injuries as well, hypothermia. And remember, so you just need to assess the patient. So all the steps you just go through the assessment as well. So this covers your primary survey. So remember, primary survey is a rapid assessment that you do to stabilize your patient. It's not the complete workout for your patient. It's just there for you to find any time critical injuries and stabilize the patient, so you can do more in-depth assessment of your patient. Okay, so once you finish your primary survey, you can move on to your secondary survey. And remember, anytime that you do your primary secondary survey, anytime the patient deteriorates, stop whatever you're doing and always go back to CABCD, right? And if you don't think you're going anywhere with the patient, always just go back to ABCD again and again. Look for these issues, so you will somehow find any reversible things, and you can sort of hold on to the patient till any help arrives. So secondary survey is usually a head-to-toe assessment. You can find really good videos from ATLS in YouTube for adults. So the principle is still the same. So you go head to toe, you check the front and the back as well. So look at all the surfaces, look at all the orifices, cavities and extremities. So when you go from head, you look at the scalp, the eyes, maxillofacial bones, so you feel for the bones and fractures around the eyes or nose or the skull as well. Look at the spine, the neck, the perineum, the cardiovascular status, chest, abdomen, limb, pelvis, and also remember you need to do a log roll as well to see the back of the patient. Okay. PR examination in children, well, that's a bit of tricky thing to do. You probably need to get your senior person to do it, because sometimes the children may not like it, and you will not be finding much very important data in it, so it's not wise to do it multiple times. Yeah, so it depends on your patient, but it's not something that I would rather do in each and every patient, but I will consider my the situation if I'm thinking of a rectal examination. And also in secondary survey, you consider the investigation. So trauma series of x-rays contain lateral C-spine x-ray, chest and pelvis. You can always you also get down your full blood count, your coagulation, your liver function, renal function, the cross match, which is important. And you can get your fast scan as possible. And you can also consider CT scan if it's available to you and if your seniors think that's necessary. And with that, you establish, so think plan for the monitoring of this patient, send the bloods, get the x-rays, and consider ultrasound and pelvic chest x-rays, ultrasound abdomen chest, as well as x-rays as well. Also, you need to consider putting an orogastric tube or nasogastric, but if you think there's a basic skull fracture, better to go with orogastric tube to decompress the stomach, and also catheters as well. And the last but not least is the analgesia. And as a part of your secondary survey, take a quick ample history. So ask for any allergies, ask for any medication, especially when it's something like blood thinners or beta blockers. Ask for any significant past medical histories. And since you'll be thinking of surgeries for this patient, ask for the patient's last meal, as well as the events surrounding the injury. and once the patient is stable, you will consider referral to other subspecialties, or like especially like if you need intubation, or if you need to transfer them elsewhere to a tertiary center. And when you think of transfer, please continue think of stabilizing them for the transfer as well, and ensure they are safe transfer or retrieval. In summary, the approach to serious injured child consists of primary survey, which is the most important thing that we expect you as from your interns. So it contains your CABCD approach, and we looked at something a little bit on resuscitation, secondary survey as well, and something on emergency treatment. And that's where we need your part is much appreciated, and then you can also practically you can learn with establishing definitive care with your seniors as well. Right, thanks for your time, and good luck with your internship, and we hope to see you in the hospital soon. Thank you.
Then lunchtime, please come 12:15 now.
අපට කිව්වද ගාමිණී අපට
Good afternoon. I am Dr. Punyani Bandhutilaka, pediatrician at Hospital. Right. Today I am going to speak to you about communication skills and interpersonal skills in healthcare. So you are budding doctors and now you are going to start your internship program. So as new doctors, what do you think? Is communication helpful in your day-to-day life, and also do you think it will be helpful in your healthcare practices? So actually communication is a critical success factor for life. The majority of the perceived ability for communication comes from how you communicate. Actually, what you know matters a little bit, but how you communicate matters a lot. So your content matters a little bit, but how you communicate or how you put it into words matter a lot. Right. So communication is, of course, sharing of one's feeling and understanding. What is effective communication? Effective communication is to express oneself in such a way that one is readily and clearly understand the content and also the feelings of the other person. And also, not only that, to respond. Right. So what are interpersonal skills? Interpersonal skills are the skills or the capacity for recognizing our own feelings and those feelings of the other people, so that we can motivate ourselves to manage the emotions of the other people effectively.
and also the emotions effectively in ourselves as well as the others. So that is called emotional intelligence. So communication in healthcare. As doctors, do you think communication is helpful in healthcare? What is your idea? Any guesses? Yes, it is very important in healthcare. Actually, we have to communicate with so many people during our ward round, during the ward work, when we are dealing with people. So many people we have to deal while we are working in the hospital. So sometimes we have to tell them very intimate information, but the information has to be very accurate. And sometimes we have to developmental delay, revisions, abuse, child abuse, cancers, fatal illnesses, all those things. Sometimes we have to communicate with the patient. So how are we going to do that without hurting the people? So patients will be they will relieve their anxiety and distress. Their hidden problems will be answered if we communicate well, and patient will be more satisfied at the end. And they will not go doctor shopping from here to there, and it will reduce the cost of the healthcare, and there will be fewer malpractice suits. So why people get dissatisfied? It can trigger patients' doubts about the competency of our physician. It can seriously reduce their compliance with the treatment, can negatively affect how long they will take to recover from their illness. And also dissatisfaction can increase the frequency of malpractices. So dissatisfaction is not good when we are communicating. Why? To alleviate that, we have to become good communicators. So doctor-patient relationship. Being doctors, you all have a particular responsibility to develop effective interpersonal communication skills. So, what percentage of communication you take? Any guesses? Anybody want to answer this question? What percentage of your communication you are responsible for? Any guesses? Right. It's 100% actually. So you are 100% responsible for your own communication. So when you are going to communicate, your first impression matters a lot. What are those? Your physical appearance, how confident you are, being alert, being gentle, smiling, everything matters when you are going to communicate. So when you are going to communicate, you have to show some respect, introduce yourself by your name, greet the patient or the parent appropriately, maintain some privacy. So you can choose a not very busy place to communicate, be pleasant. You should have a correct balance between the formality and friendliness. We can't be too friendly with the person we are going to communicate, but we have to have a good balance. Give some courtesy, attention, pay attention to their problems, pay warmth, and use appropriate language, so that simple language where they can understand us. No jargon. So, my next question, what percentage of communication is just given by the words? Any guesses? So actually all are not interacting with me. So please listen to this carefully. This is very informative, not only for your day-to-day personal skills, but also for your postgraduate examinations as well. So if you interact nicely, we can go. So what percentage of communication is given just by the words? Any guesses? It's actually 7%. What you formulate and matters only 1%, but they should be proper and structured. We can't go and just telling, but we have to plan them and an objective when you are going to come. What percentage of communication is just given by the tone? What is tone? How you put it into words? Your tone. Well, it is 38%. So the tone matters a lot. What percentage of communication is just given by the physiology? What is body physiology? Yeah, your body language, your gestures, your face. So your body physiology matters 55%. So think your words matter only 7%, where your tone, your body physiology matters a lot. So communication is not just giving some words, but it is how you put it into words. Right. Sometimes you are going to give a message, but the message can get distorted. Why? Like this, for example. Why it is distorted? Because no active listening is there. So in communication, active listening is also playing a big role. Listening is the process of receiving, constructing meaning from, and responding to spoken and non-verbal messages. Okay, so you have to be, while you are communicating, you have to listen as well. So listening is a master skill which is rarely taught to us. The competency should be achieved through practice. A good listener is not just a receptacle, but to be an effective listener, you must respond verbally and non-verbally. Right. So effective physical attending behaviors are also very important while communicating. So if you read it from top to bottom, FELOR, fellow, if you can remember it nicely. What is fellow? Face to face, eye contact, leaning forward, open posture and mind and be relaxed. So while you are communicating, you have to maintain your posture, your face to face. Then you have to maintain eye contact, lean a little bit forward, have an open posture and a mind, and be relaxed. So those things are very effective when you are going to communicate. So as I have told you earlier, listening will help to build good relationships. It will solve problems. It will ensure understanding, resolve conflicts, and also it will improve the accuracy. So at work, effective listening means few errors, few wasted time. So what are the barriers to active listening? It can be a very crowded, noisy environment, or maybe the person who is listening can be preoccupied with something. No. This is not that. This is something else. So, however, we are going to divulge some knowledge to him, he may not accept it. Or speaking all the time rather than listening, judging rather than listening, and also sometimes ignoring non-verbal cues. What are the non-verbal cues? So, crying, all those things. So their facial expressions will give you lot of non-verbal cues. Right? So there are several ways of listening. You can totally ignore what the other person is telling, or you can just surface listen, get the content, or you can become an empathic listener. What is empathic listening? You understand the content as well as the feelings of the other person. So empathy is to put yourself to the patient's position and see, if this happens to me, what will I do? So if you think like that, you will realize how painful, how difficult their situation is. So empathic listening is telling as well as non-verbal cues. Right? So we will see some examples. Empathic listening. If they keep my child in the hospital too long, we are getting disturbed all the time. If they keep my child in the hospital too long, I wonder what will happen to my job. So mother is feeling, any guesses? Is mother happy or worried? Yes, mother is anxious and worried of losing her job. So next one. Oh, the doctor said I could go home. The child is feeling well. So what is the underlying feeling? They are happy. I was really hoping that I would get my transfer to Candy. The nurse is feeling disappointed because she is not getting the transfer. So how can we formulate an empathic response listening to them? So we have to include our feelings with the content, right? A mother says, today she slept well and didn't cough in the night. The mother is feeling happy. How to formulate an empathic response to the mother? Oh, You're happy because the child slept well and you think the child is recovering from asthma, right? So that is how we can formulate an empathic response where we have recognized that the mother is happy we can ask open-ended questions like, tell me all about your illness, or what would you do if, likewise. So they will come out with lot of details. Then there are certain other ways of questioning, like specific questions. So where seek to answer a particular point. Amma babata kipara kakka. So they will tell 3-4 times today. Likewise, or you can ask close questions. Pamanit giyad? Yes or no. Yes or no. So likewise, you can ask specific questions, close questions, or building questions like, in what way do you think we can help you? Why do you say that? Then they will come out with their problem. So also we can use clarifications at the end of our communication, like, what I hear you say is, or what you seems to be saying is. So if we clarify what we have told them or what we have got out of them, sometimes they may have forgotten something and they will realize they have not talked about their urine output or not eating and drinking well, and they will come out with their other something else as well at the same time. So these types of questioning is very important to get lot of information from the patients so that we can arrive at a correct diagnosis. Appropriate touch is very helpful in communication, can mold the behavior of the patient, but we have to use it appropriately. What is rapport? Building a good rapport with your patient is very important in communication. So alignment helps to build a good rapport. There comes matching and mirroring like this. So how can you mirror when you are on the phone? You can use the same language, the same tone, same volume, the speed, everything. If you do that, the person at the other end of your communication will feel like she's just like me, she's relaxed, she's listening to me. So matching and mirroring helps to build good communication. Pacing and leading. If your level of rapport is good, it can possibly alter the physical posture, actions, which in turn change their situation, their emotions. So at the end of your story, at the end of history taking, or at the end of your communication divulging bad news or something like that, you can summarize. So all what I have told to you is the child is having a childhood asthma and it needs medication. So we are going to prescribe you with this inhaler, which you have to take morning and evening. Is there anything else you want me to tell you? So likewise, you can summarize what you have told. So they will get it into their head more. So it helps to clarify matters, indicate that we were listening. It is all about their problem and their management plan. So when you are going to communicate in healthcare, sometimes you have to confront, maybe with your own colleague, maybe with the senior, maybe with your juniors, nursing staff, but you have to confront empathically. So you must not elicit defensive reactions in your client or the colleague who may be feeling threatened because of your confrontation. So how to confront someone about an action or behavior that you would like to change? Confront empathically. So this is one situation where a hemophilia patient named Saman, he has had a bleed into the knee joint and now he has a very big joint after convalescing bleed. So now we have to arrange physiotherapy, but he is not happy. The physiotherapist has planned some physiotherapy, but he don't want to get this. He is telling, I'm not going to bother with this dumb exercise. The physiotherapist can do that for me. So now we have to confront someone and tell that is wrong. So how are we going to formulate an empathic response? So you select what is the best. No, Saman, you have to do the exercise. Will he be happy? No. Oh, that's really poor attitude. What's the problem? Will he be happy to do the exercise? No. You made a commitment to the physiotherapist that you would do the exercise on your own. Will he be happy? No, it's quite boring to do the exercise. But it's very important you do that. Is there anything in particular about the exercise that you don't like, Saman? How about that? His problems for not doing exercise, and we can help him. We can sort out his problems, and we can motivate him to do the exercise in a better way without confronting him. So that is how we can formulate an empathic response while communicating. When we are communicating, confidentiality is also very important. We have to maintain patient's confidentiality all the time. So, doctor-patient communication, the important aspects we have learned today. Respect and warmth, you have to pay respect to them. And warmth, use appropriate words. The tone and the body language matters a lot. Active listening is very important in communication. Be empathic. Empathic listening, formulate an empathic response. Questioning and clarifying will help your communication a lot. Use appropriate touch. Build a good rapport. Summarizing helps in communication. Use appropriate confrontation when needed and maintain confidentiality. So sometimes you have to encounter angry or demanding patient. This is a very challenging and difficult situation. So active listening will help. Keep your tone to a minimum. Form an empathic response and restate and clarify what you have told. So communication with your co-workers. Who are the co-workers? Your doctors, your colleagues, nurses, attendants. So use your interpersonal skills all the time. So pay some respect and warmth to them. Convey your points clearly. Listen to them. Value their opinion. Be empathic. Give constructive criticism about them and build an effective team. So if you are very helpful, be friendly, give constructive criticism, you can build an effective team for good healthcare. So how are you suggesting constructive criticism for a co-worker? Should not be in front of a patient. Don't confront anybody in front of your patients. Should be done very privately. Be constructive. Get to the point. Avoid blaming. So if you have found out mismanagement of a co-worker, what are you going to do? Actually, if you do the communication in front of the patient, it will breach an important aspect of your professional behavior. The confidence of the patient towards the healthcare will be lost. So patients will feel very anxious and angry about our management. So should not be done always in front of the patient. We have to go to a side and communicate. So how to improve our communication skills? Actually, self-awareness is very important, that we have to improve our communication skills. It's an honest, active process of learning about ourselves and personal reflection, knowledge and the strengths and weaknesses. You have to acknowledge your strengths and weaknesses and practice during your day-to-day work. So facilitate by keeping a personal diary. So in summary, communication is a skill which can be achieved by practice. It is a critical success factor for your life, throughout your life. So at the end, both parties will be happy and you'll have less problems. So the desire has to come within you. Thank you.
Right. Can you hear me all? Good afternoon.
Yes, I can hear.
Okay. Right. So we are going to discuss today on acute management of poisoning in children and snake bite within this 45 minutes. When we discuss about acute management of children, we should be clear about at the end of this presentation, you are supposed to know the structured approach to a child with acute poisoning and to understand the protocol for the treatment of the child with poisoning. Right. So when we talk about poison versus poisoning, anything can be poisonous when somebody have it in excess amount. But what is more important is the concept of poisoning, because it causes morbidity or mortality by ingesting a chemical. So what are the toxins or poisons when we talk about? Poisons mainly in our surrounding, there are two main groups. One group is natural toxins and the other group is synthetic toxic substances. Even in toxicology, there are two branches, toxinology and toxicology, based on the subject on natural toxins or synthetic toxic substances. One of the commonest toxic substances found in our nature is drugs or pharmaceuticals. Other chemicals that can be toxic can be agricultural chemicals, household chemicals, and various chemicals used in industries. So how can we get poisoning? How can poison enter into the body? There are many mechanisms. One is surface contamination. It can be skin or mucosa, ingestion or injection. Most of the poisoning occurs after ingestion of poisonous substance. Surface contamination with contact of skin or mucosa, like contamination with ice or inhalation. Inhalation is also another method. Injection is not common with the usual chemical substances, but in toxins like animal toxins, insects and snakes can inject toxins into the body. So the assessment you can divide into main two parts. Primary assessment, if patient is very severe and very compromised, you have to assess airway, breathing and circulation, which is an unfocused assessment of patient for resuscitation. But if patient is not that severe, who doesn't require resuscitation, you have to go for the secondary assessment, which is the D. It is poisoning assessment and management, which is a focused assessment. In the assessment of poisoning management, you can do initial clinical assessment. You have to take history clearly. You have to ask about the name of the poison and suspected amount and the time of poisoning. And then you have to examine the patient for various clinical manifestations. It can be respiratory, it can be cardiac, it can be renal, or any other manifestation you have to examine clearly, which helps in the diagnosis as well as in the management of poisoning. After proper examination, you have to investigate. You have to do these basic assessments. You have to do hematological assessments like full blood count and ESR. Biochemical assessment, you may have to do CRP, full blood renal functions and liver functions. And ECG is also the important assessment in poisoning investigations. There are three main categories in management of poisoning, which is decontamination, elimination, and decontoxification. That is the specific management of poisoning. Other important aspects of poisoning management is supportive care. This supportive care, depending on the failing system, if there is a respiratory failure, you have to support respiration. If there is failure of circulation, you have to support circulation. If there is failure of renal function, you have to support renal function. If there is failure of liver function, you have to support it. That is supportive care. At the same time, you have to manage the complications of poisoning, which are, if there is a convulsion, you have to manage convulsion. If there is hypoglycemia, you have to manage hypoglycemia. If there is electrolyte abnormality, we have to manage like that, the complication management. But in acute poisoning, the three main steps of decontamination, elimination, and detoxification is extremely important in the initial management. So, initial resuscitation, airway breathing circulation, and after that, under D, the decontamination, elimination, and detoxification comes in poisoning management. So, what is decontamination? So, decontamination is removal of poison before entering the circulation. Before entering the blood circulation, you remove the poison. So if it is the skin or mucosal contamination, you can do the surface irrigation. If it is an ingestion, you can do gastric lavage, endoscopic removal, or single dose activated charcoal to remove the poison from the stomach, which is before the absorption of poison. Before entering into circulation, you remove the poisoning known as decontamination. Then elimination. Elimination is the removal of poison after entering the circulation. Removal of poison after entering the circulation is known as elimination. Detoxification is within the tissue, we destroy the poison after entering the circulation. After entering the circulation. So you can see this 4 steps. You should be familiar with these 4 steps clearly in the management of poisoning. So how do we remove poison from circulation? Elimination. There are indirect methods. If you want to take note, I can leave little time. Just copy this, the elimination technique. Right. So then we can, next step is elimination. Elimination techniques, you can see it. Removal of poison from the circulation. There are indirect methods and direct methods. So indirect methods are multiple dose charcoal. Direct various acid and alkaline diuretic techniques. The direct methods are dialysis and plasma paralysis. So you can take this because this is right. So did you copy this? Because these are highly summarized slides. So these two are very important. The effects, the decontamination steps and elimination steps. So then the next step is detoxification, that is inactivation of toxin within the tissue. For that, we require antidotes. For that, we require antidotes. Antidotes we use are, all the poisons doesn't have antidotes. Some of them have, so I am giving you a list of antidotes, so you can copy those antidotes. Before that, I will tell you several mechanisms we use in detox, decontamination and elimination. Gastric lavage. It is a very also rewarding technique, effective within 2 hours of poisoning. Sometimes some believe it is only effective within the first hour of poisoning. And if you do gastric lavage, you have to assure airway protection is complete. And you should keep the patient in left lateral head down position. You have to use very wide bore orogastric tubes, not nasogastric tubes, orogastric tubes. You can imagine the size 24 gauge, sometimes more than that in older children. Properly positions and accurately the position is confirmed. And we have to use oral airway to prevent biting. And normal saline 10 to 20 milliliters per kg should be given. Cycles. In small children, you can give 5 milliliters per kg, but others you can give 10 to 20 milliliters per kg. Usually, we have to do about 3-4 cycles, but if it is a visible pox poison, you have to do the gastric lavage number of times until the effluent is clear. If it is a clear one, you don't know the duration, then 3-4 cycles you can continue. Though it has got many side effects. It has got aspiration side effects. It can cause rupture of esophagus. It can cause pneumothorax. So large number of side effects, and but it is socially very rewarding. People think we remove the poison from the body, and it is not a very effective procedure. Some developed countries like United States, they have given up this procedure. In Sri Lanka, some centers it is doing frequently, but if you can avoid this, it is best if you are confident with the other steps of poison management. it is unproven, as I mentioned, it has unproven efficacy, high rate of complication, and very rewarding socially. So activated charcoal, single dose, as I mentioned you, single dose activated charcoal also a method of decontamination, because single dose activated charcoal absorbs the poison in the stomach and removes from it. So it is a kind of decontamination. It is very effective method and effective within 2 hours of poisoning, except for the substances with delayed gastric emptying. And the dose is 1 gram of charcoal per kilogram. So you can give it via an orogastric or nasogastric tube, or can encourage drinking. Charcoal is black color powder. You can dissolve it in water, and it is a tasteless substance. It has no taste. And it is effective, not effective in some occasions, like heavy metals and metallic substances, iron, lithium, mercury, cyanide, like that. And it is not effective in acid, alkaline, and alcohol also. Then, if you consider multiple dose activated charcoal, the action is different. Multiple dose activated charcoal is you give repeated doses of charcoal to pass through the gastrointestinal tract. Then what happens is that the poison which is excreted into the intestine through the enterohepatic circulation is trapped by activated charcoal. So then the multiple dose activated charcoal is a method of elimination, because it removes the poison, absorbed poison from the circulation. So enhanced elimination by either interrupting enteroenteric or enterohepatic circulation. That is the definition, because it takes out the toxin in the circulation. It may reduce absorption of controlled release drugs and also oleander seeds. The dose is slightly high, 1 to 2 grams per kilogram, repeated every 4 hours. Every 4 hours till the toxic level goes down in the circulation. There are other methods of elimination we don't perform routinely. Forced urinary alkalinization, forced urinary enuresis, saline diuresis, multiple dose charcoal, dialysis, extracorporeal removal of drugs like hemodialysis, and charcoal hemoperfusion. These are all methods are used in elimination, but the most frequent method out of all these is multiple dose activated charcoal. Under detoxification, these are some antidotes. So you can see the name and the antidote: poison heparin, antidote protamine, poison iron, antidote. These are list. So I can allow little time for you to copy these things. There are a list of substances. So you can copy these antidotes, and then I am going to put another list. So there is another list. Next slide is again another list of antidotes. You can copy this. These are some of the available antidotes in Sri Lanka. This list also important. You can copy this. right? So now we completed the 4 steps of poison management. Decontamination, which is effective within first hour. Elimination, effective within 2 hours. Detoxification is applicable if the antidote is available. And one of the most important steps in poison management is supportive care. It's effective all the time. Supportive care is whatever the complication of poisoning, manage depending on the complication, hypoxia, anemia, renal failure, liver failure, circulatory failure, like that, all the complications you manage depending on the, according to the protocols in all situations. So any questions regarding the acute poisoning management? We don't have time to discuss each and every poison individually. So what I discussed was the principles of poison management in acute situation. Any questions? Any questions? Or if you have questions, you can put into the chat box even. Quickly, because I have to cover up the snake bites as well. Any questions regarding acute poison management? Can you hear me all? If there are no questions, I am going to go to the summary. So you should know the principle of poison versus poisoning, the management steps of A, B, C, and D. The D, under D, you have to do decontamination, elimination, elimination, and detoxification. Decontamination is removal of poison from the surface. Elimination is removal of the poison from the circulation. Detoxification is inactivation of the poison within the tissue. Supportive care is the managing the whatever the failing tissue, failing system. Is it clear? Are you clear about poison management? Can I go to the snake bite management? Can you hear me?
Yes, sir.
Right. Right, I'm going to start the next presentation on snake bite management. We are at the end of this presentation, you are supposed to understand the structured approach to the child with snake bites and to understand the protocol for the treatment of the child with snake bite. Being a country with large biodiversity, we have got large number of non-venomous snakes and few venomous snakes. The venomous snakes, few of them are highly venomous. They are cobra, rhesus viper, crate and hook-nosed viper. There are two types of crates, Indian crate and Sri Lankan crate. Altogether, those are about 5.
Excuse me, sir. We can't see the screen.
Snakes. Can't see the screen?
No.
Can you see the screen?
Yes, now we can.
Can you see the screen now?
Yes. Yes, sir. Yes.
Okay, right. Then these are some venomous snakes, 5 venomous snakes, cobra, rhesus viper, 2 crates, Sri Lankan and Indian, hook-nosed viper. Then like in acute poison management, the snake bite management also, the first part is primary assessment, unfocused airway breathing and circulation. Secondary assessment is focus, which is snake bite management. Then snake bite assessment, you do the clinical assessment, history examination, and you can do the investigation assessment later. History, you have to ask about the time of the snake bite, site of snake bite, at where they got it, and any features of the snake if they can remember. Examination, you have to do the general examination and system examination, and special focused examination to look for the features of snake bites. In Sri Lanka, venomous snakes produces 4 categories of manifestations. One is coagulopathy, other one is neuropathy, other one is local manifestation, and non-specific manifestations. All these 4 manifestations are extremely important determining giving the specific treatment. Snake identification can be indicated, but it has some problems in handling of snakes, and being a country, we have got only polyvalent single antivenom. Whatever the snake original one has bitten, we give the same antivenom. So specific identification is not essential always. And others is investigation. I will mention the investigation later. So coagulopathy assessment can be done clinically. Then you have to look for mucosal bleeding from the gums, subconjunctival areas, genital areas, mucosal bleeding. Then bleeding from puncture sites. Those are fang mark sites and mini puncture sites. Then you have to look for any passing blood with vomitus, stool, or hematuria. Investigations, you can do bedside investigation. The commonest one is whole blood clotting time. Laboratory investigations are prothrombin time and INR. Neuropathy assessment is fully clinical, which is respiratory paralysis assessment, limb and trunk weakness assessment, eye manifestations like diplopia and ptosis, and dysarthria assessment. Non-specific symptoms are vomiting, abdominal pain, backache and headache. All are extremely important in the diagnosis of severe envenomation. Local manifestations can be the size and the nature of fang marks, edema of local site, redness, pain and tenderness, blistering, ulceration and necrosis. Snake identification. I am not going to go through snake identification. It is a lengthy subject. Snake bite guideline issued by Sri Lanka Medical Council Association is available online. It is a PDF version. You can see this. You can browse it for guidelines for the management of snake bites SLMA. The last issued 2021 guidelines counts. How to manage snake bite? Before admission, at home, they can have some first aids, wash and clean the area, minimize minimum mobilization, no tourniquet, analgesia with paracetamol, no NSAIDs should be used. After admission, specific management is antivenin. It should be given as earliest with proper dose. Supportive care, as I mentioned in the acute poisoning, whatever the failing system, you have to manage. Then complication management. If already complication has occurred, you can manage each and every complication individually in the management of snake bites. Then management of complications of antivenin. The commonest complication is hypersensitivity and serum sickness. You have to manage that also if you have given antivenom. Use of antivenin. Currently available antivenin in Sri Lanka is a polyvalent antivenin. It is effective for cobra, crate, and Russell's fiber. It is not indicated for hump nose viper. It is available in powder form vials. Each vial needs reconstitution with 10 ml of sterile water before you give it to the patient. Initial dose of antivenom. In all ages and weights, the initial dose of antivenom is 20 vials for Russell's viper and 10 vials for crate and cobra. So it is updated recently for Russell's viper. Initially you have to give 20 vials. Other snakes you have to give 10 vials. Subsequent doses you have to give 10 vial multiples. But repeated multiple doses are not encouraged, and alternative, more effective measures and supportive care should be considered in continuation in the prolonged envenomation. In infants and small children, administration of antivenom can be given directly with an infusion pump without redilution. But in older children, the reconstituted antivenom can be further diluted to make a total of 400 ml with normal saline. Anaphylaxis management should be ready before starting antivenom. Anaphylaxis management should be ready before starting antivenom. And hypersensitivity manifestation should be carefully monitored. If features of anaphylaxis present, immediately activate anaphylaxis protocol. Our antivenom has got very high incidence of hypersensitivity rates. So you have to monitor antivenom anaphylaxis features continuously. If features of anaphylaxis present, immediately activate anaphylaxis protocol, which is adrenaline and adrenaline. No other treatment. It is always adrenaline. Adrenaline should be given 1 in 1,000 intramuscular injection 0.01 per kilogram, body weight 1 in 1000. You can repeat in every 5 minutes, 10 anaphylaxis features disappears. Every 5 minutes you can repeat. There is no mention upper limit of doses, but usually with 4-5 doses of adrenaline, anaphylaxis resolves. No need of giving intravenous infusions of adrenaline. Repeated dose of intramuscular adrenaline can be sufficient. Then resistant and complicated cases like resistant coagulopathy, resistant neuropathy, specific organ failure like renal failure, multi-organ failure, and severe local manifestations, you have to ask for local expert opinion. In resistant coagulopathy, instead of repeating continuous doses of antivenom, you can consider alternative methods like FFP, fresh frozen plasma infusions, and plasmapheresis in resistant coagulopathy. Resistant neuropathy, like respiratory failure, requires prolonged ventilation. Specific organ failure should be managed with supportive care. Multiple organ failure is the same. Severe local manifestations can be managed with severe local manifestations should be referred to surgical team for surgical management. So, any questions regarding snake bite management? Snake bite management is very easy because we have got polyvalent antivenin. The most important thing is correct diagnosis with envenomation. Look for coagulopathy, neuropathy, local manifestations, and non-specific features. Once you decide envenomation has occurred, give antivenin. Proper 20 vials initially for Russell's viper, 10 vials for others, and subsequently 10 vials for all the snakes. You have to manage anaphylaxis. So coagulopathy, neuropathy, local manifestations, and specific manifestations management. And you should know how to use antivenin and management of complications. So these are the snake bite hotline in Sri Lanka Medical Association. Snake bite identification separate information hub. So you can copy this. And then SLMA has got guidelines for the management of snake bites in hospital 2021. You can see the link. In the management of snake bite guideline, there is a separate chapter for pediatric snake bites. So you can go to that chapter and read the specific or the more relevant pediatric parts in the management. Thank you.
Right. Thank you, sir. If you all have any questions, you can ask or type in.
Yes, if you have any questions, you can ask anything. If you want, you can put in the chat box.
This is the last lecture for the day.
Okay, right. So this is on patient safety in healthcare. So I'm Dr. Srila Disilla, and I'm going to speak to you very briefly on the patient safety. What do you really mean by this? If you don't maintain patient safety, the end result could be something like this. So this is what we don't want to happen. I'm sure you'll experience some of these during your internship, and you might be thinking, oh, if you had done that, we could have saved, or we could have done better. You know, so that is human nature. When you do these things and something goes wrong, and if the end result is something like this, it's very worrying. So what do you mean by patient safety? It's prevention of harm to the patient. It's from freedom of accidental injury of any kind while receiving medical care. So the other thing is absence of medical errors or adverse action undertaken to protect the healthcare recipient from being harmed by the effect of the healthcare services. Now, when you call patient safety, this is also important to consider. The other important word is quality. The patient safety and the quality is the standard which must be applied in order to make sure that the patients are safe. So the World Health Organization has identified safety goals, few safety goals. Goal one is identify the patient correctly. Goal number 2 is improve effective communication. Goal 3 is improve patient safety of high alert medication. Goal number 4 is ensure correct site, correct procedure, correct patients for surgery. Goal number 5 is reduce the risk of healthcare associated infections. And goal 6 is reduce the risk of patients' harm resulting from falls. So all these things have a separate chapter, separate descriptions, and we need to follow in order to reduce the unwanted patients' issues, safety issues. Why patient safety is important? Because there are a lot of medical errors, and medical errors are considered as the third leading cause of death in the United States. This is in 2016. So, which means in a country like ours, we can imagine it all goes unrecognized. That is the danger of it. Right. Then what are the common errors in healthcare? One is unsafe medications and treatment, healthcare associated infections, then injuries due to medical devices, surgical and anesthesia errors, unsafe injections, unsafe blood products, pregnant and newborns, then injuries from patients' falls, and poor care for elderly. Now, what is near miss? Near miss is an act of commission or omission that could have harmed the patient but did not cause harm. Although it did not result in injury, illness, or damage, it had the potential to do so. So that is what is meant by near misses. So the adverse event, the definition is the event that results in unintended harm to the patient by act of commission or omission rather than by the underlying disease or the condition of the patient. So for example, if the patient comes get admitted with pneumonia and develop a cardiac arrest and then become sort of a brain damage, that is basically sort of in respect of the underlying condition, patient has ended up with some permanent damage. So that is unintended harm. Now, this is Andrew Murray, who is a famous tennis player. You can see this patient is a right-handed tennis player, and his IV cannula is on this side, and blood in the IV cannula, and the top is open here, and there are two IV lines connected to the one single line. So all these things causes causes harm to the patient than treating the patient under. So this patient was admitted for a hip surgery, and this is how he was treated. So his lawyers argue that he was getting suboptimal care, and he was trying to, and they actually sued the hospital for giving his suboptimal care. So therefore, we find that the error is basically human. So it is not because the people are lacking the knowledge or people are lacking just skills, but purely because they don't consider patient safety issues as a priority. So what happened in the patient is the patient's harm. So sometimes we tend to blame the doctors and nurses at that time, and by blaming, these errors keeps happening. So therefore, we had to find out, are there any organizations where there are minimal or no errors? So what do you mean by minimal or no errors? These organizations consider safety as a prime priority, and the leadership is committed to open and frequent communication, learning from mistakes, and mistakes are treated as an opportunity to improve. So we want to wonder, are there any organizations like this? There are. So what are the organizations? One is nuclear organization, aviation industry, petrochemical, Formula One. So all these organizations are considered as highly reliable organizations and no areas for mistakes or mistakes. And that is because they tend to improve not only everybody is knowledgeable, everybody is skillful, but they have improved on non-technical skills. So the human factors, there are two types of human errors. One is human-machine interaction errors. The other thing is human-human interaction errors, such as communication failure, teamwork failure, and organization culture failures. So this is this slide is from Professor James Reason, who is a professor of patient safety. What he sort of highlighted in this one, there are patients are getting harmed if there is a breach in every slice of the Swiss cheese. So every slice of Swiss cheese, first slice is represented by poor protocols and poor procedures. Second slide is represented by faulty equipments, physical barriers. Third slice is missing information, and the fourth slide is poor decision, and inadequate supervision. So it's very rare for a patient to die because these holes should be in a line if a patient if the patient get harmed. Therefore, one of these slices actually move up and down and trying to prevent the patients getting harmed. But unfortunately, if these lines are all in one line, then patient can get harmed. So this is why you need to think about the patient's safety. You need to think about all these factors and trying to prevent the patient deteriorating by putting this each strategy in place. So on the other hand, human beings make mistakes because the system, the task, and the process they work are poorly designed, not because sometimes they are not poor knowledge, they are not skillful, they are skillful, they are knowledge, but still this can happen because the system and the task and the process they work are poorly designed. So this is one of the few reasons why these harms can occur. Patient safety is compromised. One is system errors, other one is group or human errors, other one is individual human errors. So if you take individual human errors as details, there may be a bad day because some days are very bad and some days we get very bad patients, some days are really good. Then biological factors, some days they are fatigued and they are exhausted and no food hungry. And then other thing is they have ego or temperament and knowledge gap, training, and their previous experience on a similar incident. So much of these things are actually due to, as I said before, ego. So too much ego sometimes will kill your talents and patients get compromised. So the issues at the hospital sometimes causes patient safety or compromise, isn't it? If this paper article is from one of the incidents that happened at Galaheim Rural Hospital, Divisional Hospital, after child dies, and then the crowd really went rampant and violent and really damaged the doctor's vehicle, the hospital, and then ended up with a disaster. So when you have a crisis situation in a patient like this, where things are getting out of control, I think you need to have a structure how to put it right. So probably maybe the ABCD approach, airway, breathing, circulation, disability assessment, and whatever we can do to correct that. So therefore, the healthcare workers are basically knowledgeable and skillful, and no one comes to do a bad job. But having said that, this type of things happen in the hospital, and it is basically due to non-technical skills, poor knowledge and non-technical skills. So the best example is Formula One racing. In Formula One racing, everybody knows what to do, and within a short time they put everything together and try to sort of get the vehicles on the track again. So therefore, this is we need to act like a patient safety. Where at Formula One, we want to improve the efficiency of improve the patient's outcome. So they recognize the importance of teamwork and team training, and individual skills and competencies is not enough. So this is the basis of the crisis resource management principles. It's called CRM, which came from aviation. So what are the principles? One is effective anticipation. So we should know what type of the patient that's going to come, and what type of resources or what type of facilities are available and services that can provide to this patient. And also it's important to recognize that this patient is serious and needs help or needs help urgently. Then we need to appoint a leader if I'm working in a team. So that leader should stand the foot in, and we need an airway person, you need an evaluation doctor, circulation doctor, then somebody to go up and down to bring pieces, and then somebody to scribe. Then equipment should be in order so that in an emergency situation, you know where the equipments are. Role allocation is important. Allocate early, appropriately. If you are not comfortable, you need to speak up and then try to move to another role. So call for help early. So don't wait until late to call for help. That's not good professionalism. You have to call for early so that your help will arrive on time. Then it's important that your communication should be on closed loop communication here, closed loop communication, and also as I think interns, you need to learn how to communicate with IS-bar format when you speak to your consultants or seniors over the phone. So this IS-bar is a form of communication that is often done by the juniors with the seniors. Then sometimes decision making is different. So now this patient, the X-ray was taken, and the doctor thought, there's a cockroach inside the chest, and you need to go to a regional hospital for surgery. But ultimately, what they found was the cockroach was not in the chest, but was in the X-ray machine. So therefore, this type of decision making can cause issues. So you need to make sure that you take the right decision at the right time in order to prevent the mishap happening. So what are the factors affecting the decision making? Hungry. If you are hungry and during internship, they work long hours, and you might get angry, you might be late for work and late for leaving, and might be tired, might be stressed. And all these factors affect the efficiency of patient's care. And when you work as a group in the hospital, there are these fractions will be there. Some may be pleasant and activated here. Some may be pleasant and deactivated. Some may be unpleasant and deactivated. Some may be unpleasant and activated. So all these categories of members will be in your group when you try to manage a patient who is crashing. So therefore, it's important that you don't belong to any of the categories except the present and activated group. So if you are in a problematic situation, very often the people who don't have much job, patients who are very on low profile, should come forward and help them to improve the situation, so that that reduces the occurrence of error and protect the team members against litigation. Then this is a fixation error. You can see this patient in one of the emergency department. He's intubated, he's connected to ventilator, and he's as a drip, and he's on his own. But the issue is, if he develop errors, there's no plan here. Who is going to give chest compressions, who is going to defibrillate, and who is monitoring this patient right now? So this is called what is called fixation error. So every possible explanation for a situation, with the exception of real emergency, is taken into account. This is what is called fixation error. What is meant by conflict resolution? When there's a disagreement on the management issues, you have to always take a decision what is right for the patient rather than what is right for a person. So this is what is meant by conflict resolution. So medication errors is another big area. Any preventable event that may cause inappropriate medication use, and that can jeopardize the patient's safety. Therefore, what we found was there's prescription errors, use of abbreviation and causing errors, and poor understanding of the administration of the medication, and poor understanding of the drugs. So wrong drug, overdose, not correct dose, spelling mistakes, wrong dilutions, drug not available are the causes for the medication errors. So there are what is called errors and also violations. So mistake is not knowing the correct drug to prescribe. Slip or lapses is knowing the correct drug but writing another one. And deliberate violation is not attempting to get the second drug checked, as there is no staff available. Routine is exceptional. The tips are set by the supervisor in order to fulfill a rush orders, not done. So if violations and errors add up, that can cause injury, damage, or the death. So therefore, patient safety is important, because sometimes we find there are VIP patients and we tend to take extra precautions in treating these patients, but not applying the same approach to all the other patients. Now, this is the last slide. I think what this says is, now, if you sort of always go abided by the protocols and the guidelines, and you think the patient safety works pretty well, it doesn't happen. It doesn't happen so. Now, this was one of the real incidents. This pilot actually, once they took it off from New York, and the two engines were struck by the birds, and then was it's going to crash. So what the pilot did was they actually landed this flight in a lake, so that nobody was harmed. So therefore, what this message says is, although we have a lot of computers, although we have protocols or guidelines, all these things in place, and people are requested to abide by the guidelines and the protocols, and not to violate all these things. But ultimately, what matters is your judgment at that particular point, trying to make the patient safe. So what this message is, the brain is equally creative and resourceful and able to make remarkable recoveries from the edges of disaster where no rules exist. That's what we want from a doctor, isn't it? You being a doctor, we don't want to sort of go strictly by the guidelines and the protocols. We want you to think rationally. We want to have some lateral thinking. You want to develop some lateral thinking. You take the right decision at the right time so that your patients will be safe. And that is what is being tested in all these exams. We no longer test your recall methods in the exams. We try to analyze your analytic ability at every exam. Especially, some of you might do PLAB, some of you might do AMC, some of you might do US exams. All these exams, there's an element that they test on this area. So there's no right and wrong answer in this one, but they simply test whether you are rationally thinking in that particular scenario. So this is what is meant by non-technical skills. So thank you very much. This is the end of the lecture, and this is called error of human error. It's an issue, and you need to improve and try to minimize human errors when you start practicing as an intern. Then that is the most important attitude, that clinical skills that you need to develop during your internship. So thank you very much.
Right. We have concluded today's session. So tomorrow, 8:15, please join by 8:15. Right. Thank you.